Okay, so good morning, everyone. If you're on the East Coast, it's definitely good morning. If you're anywhere else, you're probably way up, way up sooner than you should be. So welcome everyone to Screening, Brief Intervention, or Referral to Treatment. This is a web training brought to you by the Northeast Caribbean Addiction Technology Transfer Center. My name is Diane Padilla. I am your trainer for the next while that we're together. I'm going to go through some of the logistics. So our ritual is very simple. Before the end of the time we're committed to being here, we hear from East Coast, Eastern time from 10 to 2:30. So we are going to stop a few minutes before. We should have completed the review of the content, and you'll have enough time to click on a link or scan a code and provide us with any of the evaluation submissions on your report. That is going to help us justify sending you a certificate of completion for the 4 hours of SBIRT that you're here. And so putting your name and your organization in the chat box is especially important because that's our informal attendance sheet. And so we have to correlate that with your registration and with your participation here. We do use algorithms. So this is the team I'm part of. This is my silent partner down here, Mr. Clyde Frederick. You will hear his voice if for some reason I lose a signal. And I have to log back on. And so you'll hear his voice and he'll help to give you instructions as to whether to stay or if it's taking too long, whether we go. We've only had that once, I believe, with my presentation. So he's also the person that in case you have any kind of tech issues for any reason, you can send him a message directly to Northeast Caribbean ATTC. That's the name on the drop-down box, and he'll respond to that. Also, Miss Patricia Chappell. She is the person that most of you are familiar with in terms of getting your evaluations done, your certificates sent to you, and also a copy of the slides. And so Treat will be following up within a week or so. My name is Diane Padilla. I am a research project manager here. That is my official title. And regarding the content that we're going to discuss, I am also the screening, brief intervention, photo treatment, technical assistance, and implementation specialist. That means I have a lot of experience working, not just training the subject matter, but also working with organizations very uniquely to help incorporate or integrate the SBIRT model within their setting. And every group, every organization I've ever worked with is extremely autonomous. And so I've had the pleasure of helping a lot of folks in a lot of entities to actually incorporate this in their setting. And so this is acknowledgement. This just acknowledges that we are funded by SAMHSA. SAMHSA funds us to, and it's and all our efforts are facilitated, and oversight is done by Michael Chappell, the ED for us. Addiction Technology Transfer Center, Mental Health TTC, Prevention TTC, all falls under this umbrella. SAMHSA actually just funds these regional centers across the country to be able to provide you with workforce support, and that's especially important. It's all about informing you about best practices or current updates or knowledge-based information, as well as building your skills and competencies with different disciplines that you work in. When it comes to that particular need, SAMHSA funding the regional training centers is SAMHSA's way of providing that workforce support. And so you folks need your credentials and your licenses to be able to work in a lot of the capacities that you're currently serving, and that's why they fund us to do this. Language matters. This is going to be especially important. And so language matters, words have power, people first. I'm going to come out of my slide. I hope you all don't mind, but and this is kind of a close-ended approach, but I'm going to ask everyone that when you do speak, can you raise your electronic hand? Are you okay with that? Thumbs up, thumbs down. Very good. So this language matters slide, when we talk about language matters and people first, does anybody know what we mean by that? When we say words have power, do you know what the idea, the concept is behind having a slide like this? Joanne.
So it's mindful of your choice of words be careful and thoughtful. Remember that we here in this room are an incredibly diverse population, and the folks that we work with and provide services to are just as, if not more diverse. And how we talk about individuals matters.
Great, Joanne. Thank you for starting us with that. That's really well articulated. That is going to be incorporated into how we frame this model. This is this SBIRT model, this SBIRT content that I'm going to walk through with you is a traditional model, but it has also a very updated best practice framework. And so I'll speak to that more specifically, and includes the language we use. Oscar, hi, good morning.
All right, good morning. Well, I think that all words have power and semantics, and they have different meanings to different people, and they have different effects. So, especially in the field of counseling and any type of psychological intervention or crisis issue, how we speak and what we say will have an effect, both to the patients that we're working with and also in general practice to ourselves and how we interact with others. Words always have power.
Thank you, Oscar. And so, when you think about it, and many folks here are working directly and with the communities around substance use disorder treatment, but there's other clinicians and other professionals here who are working in different aspects of behavioral health. And what we want to consider is the kind of language we use that engages someone as opposed to pushes them away. Let's put it that way, real simple. So I always do this, and I'm going to do it again. Every given year, we tend to admit about a good 2.5 million people to treatment. But there's at least 20 to 22 million a year that do not, that can benefit from treatment, but don't get into care. Debbie, I see your hand. Go ahead. I'll finish off after.
Sorry, I couldn't
Hi,
find.
good morning.
It gives everyone a sense of belonging within the call, within the Zoom. So it's inclusivity.
It's inclusivity. Yes, that's part of it too. And so the thing is, we want to engage folks. We want to use a dialogue or the terminology to help people feel like we are right there present with them, and we are engaging them in a conversation or engaging them in whatever services. But we don't want to label folks. Stigma has been one of the biggest aspects of biggest challenges of accessing care. And so we want to be mindful of that in our language, which brings me to the next slide. By the way, we do have a break for 30 minutes somewhere along the line. We're halfway through. So I'm going to bypass that slide from the logistics and kind of just go into here. I just want to, because we're going to talk about the language piece. And a lot of folks look at the SBIRT component screening, brief intervention, referral, treatment, and folks know, oh, this should be easy. We are all familiar with this. This is very traditional to many organizations' intake process. And so it's not unfamiliar to most folks. What I want to suggest to you is to keep a slightly open mind and borrow some ideas, because the way the SBIRT model is working these days is a little more specific. So there have been some places where they would think that they're doing SBIRT, but they only do screening and referral. That's not SBIRT if you don't have the 3 components. So you can't just do brief intervention and referral. You can't just do screening and referral, and you can't just do screening and brief intervention. All 3 components is the model. And that's really important. We'll speak to that a little bit more specifically. Now, the thing that makes this a lot more different than what you're used to is how these components are facilitated. And so to help you understand that, I want you to kind of review some of the aspects, some of the things that we consider in terms of facilitating this model. So recovery-oriented language is especially important, being culturally and linguistically appropriate, the knowledge of substances and their impact. All of that is needed just to even get this started. And so the whole framework, the whole model actually has these key aspects that are applied for each and every component. And so when you do a screening, which we'll talk about soon, it's about substance use screening. So in order to do a screening and maybe have a dialogue about that, you want to be able to know something about substances and their impact. We'll unpack that some more. When we think about overall, the overall model, but even just the specific component of the brief intervention, the consistency of a public health approach and a person-centered approach is especially important. And factors for an effective referral for further assessment will be explained a little bit more in a little while. So this just gives you just a quick glimpse of what's coming. So when you think about stigma, why stigma-free, a recovery-oriented language, this is why we are talking about the the language matters slides and why words have power. A lot of times we get conditioned in our work to use terminology, particularly for those of us who have been in the field for a while, to use terminology very specifically, very appropriate, and just like we were trained, but over time, negative connotations have been associated with certain terms. And so because we want to use more empowering language, we want to discourage stigma in language because that's a barrier to care for a lot of people. That's not the only one. That's not the only factor that stops people from accessing care or supports that they can benefit from, but it has a huge one. And if we can play a part in updating or updating our language, our terminology, then we can certainly be more engaging with community members in need. And so stigma discourages people from seeking needed care or disclosing their substance use due to fear or biased judgment. And so when labels, labels come up and like for instance, say someone, if I say I'm working with addicts or as opposed to I'm working with people with a substance use disorder, just hearing it, you can tell that one word has such negative connotations. And I'm speaking for us as providers. And so that further influences how we interact and connect with the individual as well as how we, what supports that we provide. And we'll talk about that a little bit more. So let's replace stigmatizing language. We preferred an empowering language that doesn't equate people with their condition or the negative connotations. So person-first language, which we borrow from the community for people with disabilities, there it was in that discipline and that form that from person-first language first evolved. We are borrowing in that for all other aspects of work that we do in behavioral health. It just makes sense to put that person first and eliminate the labels that can help someone kind of stay away from actually returning to care or accessing care in the first place. So we want to be able for folks to understand, to have the opportunity to actually describe their conditions and we normalize it in the conversation. And so the words do matter. And so recovery-oriented terms in communication, it's all speaking to how it can influence an individual and affect the outcomes for them. So we want to use respectful, non-judgmental words. And so respectful is not just not being rude. Respectful is actually like being mindful and eliciting information from the individual, integrating their perspectives in the care that you provide. So these are the core modules. This is really what we're going to cover. Is like what's SBIRT, why do we use it? Screening for substance use, all these different components, you'll see them in title slides as we move along. I don't think I really need to speak to that or read it out loud for you. So one of the things I didn't mention is that when we're going to look at each component, but one of the things I mentioned is that each component has certain considerations that you need to incorporate as we facilitate it. Now, one of the things I did neglect to tell you initially is that this particular 4-hour framed SBIRT training has a lot of information. And so there'll be some opportunities for interactions, which is what I really like the most, but not as much as usual for those of you who are used to coming to my trainings. And so there's a lot of information to get through so you can get that 4-hour certificate. Okay, so we're going to talk about substance use and its impacts. You're going to have a substance use screening facilitated within a given individual. It might give you an opportunity, it might indicate an opportunity to have a conversation with them about how substance use may be affecting them. In order to do that, you have to have some basic knowledge. And sometimes we see certain things in our community and not as aware of other substances. There is, let me see, I'm going to put this in here. There is certain information that we tend to know about different aspects of impact with different substances. I just put in the chat box these same slides, effects of substances. And so in order to like have a conversation about, so maybe someone has a high screening score for alcohol consumption. And so in order to have a conversation with them, yeah, you would have to know some fundamentals of how alcohol impacts the body. We do know that for a lot of folks, some of the first things that kind of comes up is that there is liver damage when someone is consuming over a long period of time. You know, here's what's interesting about that folks may be consuming at a level that's causing them harm without them knowing, because liver disease is really asymptomatic until a certain extent. It takes substantial damage to the liver for it to become compensated and actually show evidence of damage, and whether it's biomarkers in the blood work or any other kind of way. And so most times damage is getting done in that organ in ways where someone is not very aware at the moment that that's impacting them. We know that it affects memory and concentration. Even if a person does not drink on a regular basis, whatever that regular basis, however that person may want to define that, it doesn't mean that they're not having maybe issues with their memory. And so what we want to understand is that alcohol has these different types of impact. It can affect the person's ability to concentrate, whether it's in school, whether it's at work, or any kind of event that they're involved in. And so that memory aspect, that part of the brain and the brain functions is affected by alcohol. It also has effects on, heart attacks and arrhythmias and cardiomyopathies. And so, and certainly, and one of the things that many people don't realize is that blood pressure is also affected by alcohol use. Again, you have the handouts and that's just to give you kind of a kickstart, but you already know a lot of this. It's just a matter of just being aware some of the basic impacts as they may come up in a conversation with a client or a person that you're providing services to. Opioids, we know that they depress the respiratory system, increases risk of overdose. It pretty much is more of a sedative process where the digestive system can slow down. Memory loss can also occur. Brain and skin and lung abscesses can happen, endocarditis. And so here we got opiates. You also have synthetic substances. This is something that most of us are probably more familiar with, because there really isn't heroin on the street. It's mostly fentanyl, and many times what we're seeing is fentanyl with xylazine. I've seen, yes, Tiffany, go ahead.
So my question is, with everything combined, is there information on that with like the mix of opioids and alcohol and such? Like, how does that all together affect the body, brain?
Well, you see them as individually what the impact would be. And so probably substance use just increases the impact and the risk for disorders that much more. I don't have a specific handout on that, but I'm pretty sure you can easily Google that from CDC and NIH websites or the Department of Health website. But what I'll do is I'll look it up, and I'll make sure that when you folks get your certificates, you get a handout on that as well. And so what you want to do is be able to, thanks for the question, Tiffany. What you want to do is be able to be familiar with what the impacts of these different substances are, because you're going to be able to have a conversation where you can use this information in a tailored way to have that conversation with the individual. So we have fentanyl as a powerful synthetic opioid, like morphine. You folks know about that. And the side effects are, synthetic opioids are, really pretty much the basis. It's fentanyl, in some places it's fentanyl and xylazine. And so mostly the effects on a person's body is the drowsiness, it's nausea, constipation, sedation, problems breathing, and so on. So here I'm going to go through. So you have one on marijuana and how marijuana can slow down a person's responses over time and actually affect their balance or their coordination, impairs their judgment. Actually, all these substances, to a certain extent, all impair judgment because they all have that intoxicating effect. Can cause immediate jump in heart rate. Even though we think about cannabis and we think about alcohol as depressants, it actually affects these. There's like with alcohol, there's a biphasic or like a rebound effect that actually impacts the body. Well, marijuana has the ability also to cause a jump in heart rate and constrict blood vessels. And so what we want to understand is the long-term effects of substance use for some folks, particularly with those who may meet the criteria of substance use disorder. They can experience withdrawal, heightened stress response. There are changes in the neurological processes of the mind, of the brain. And so it all kind of works around the judgment, decision-making, learning, memory, and behavior control. I think another point to mention here is the fact that when someone is using substances, they're not aware most times of how insidiously the addiction starts to progress and affect their thinking and their behaviors. And so, and at that point, you know, folks are more likely to meet a criteria of substance use disorder. And so I want to go over module 1. What is SBIRT and why use it? So among people aged 12 or older, and this is coming from 2021 data, you know, almost 58 million people used a psychoactive substance. Now, what's interesting is that they used it. It doesn't mean that there are going to be problems. They're going to be your clients eventually. It doesn't mean they meet the criteria of substance use disorder, but we see the prevalence of use that is much more common than we tend to see. And even though many of us are working with folks who have some of the content here is going to apply with the population that you work with, it doesn't necessarily dictate automatically a particular end result. But we do see how common this is. Now, 47.5 million people drank alcohol. Almost 20% or 55 million people use tobacco. More than 14% use an illicit drug. That's 40 million people there. From the transgender and gender diverse community, we see on over 41% of those folks reported past year marijuana use, and almost 7% of them had indicated that they misused opioids. So the prevalence of substance use is common, and it's pretty widely documented at this point. So when we look at it from a community perspective, and this might help you kind of relate some of this information to who you're serving. So substance use has a disproportionate impact on racial and ethnic communities and gender diverse communities. SBIRT requires culturally responsive care. So that means culturally responsive care is respectful of and responsive to the health beliefs, practices, and needs of diverse individuals. And that's how I define personally and professionally, how I define respectful service is being responsive to that person, that individual's perspectives, their habits, their knowledge base, their capacities. And so for that to be responsive to that, I would have to actually elicit that information from that individual. And so what we can see, and that really encourages that culturally informed approach with working with different people. So here we see Indigenous people, about 56% of Indigenous people had used some kind of substance. Now we're thinking about substances about alcohol, both illegal and illicit substances, alcohol, opioids, tobacco, all of the above. 34.5% or percent had used substances. Multiracial, and you see the numbers going all the way down: the Black and African American community, the white community, Hispanic, Latinx community, Asian. And then we have even other perspectives, other trajectories we can use. So think about the rates and impact of alcohol use. Now, we are very familiar that the opioid overdose has been consistently over 100,000 people who have transpired and have succumbed to their overdoses. What we don't always talk about is alcohol use. Every year for the last many years, alcohol-related deaths, deaths are attributed to alcohol being involved in some kind of way or another, and has always been over 100,000. Not a lot of focus on that, but I just want to make sure that we are aware it is just as high and just as problematic as the opioid use and overdoses. So every year in the US, more people die of alcohol-related causes than from opioids and other drugs. For individuals up to 80 years of old, 80 years of age who drank alcohol, 1 in 4 reported having 6 or more drinks. We're going to go over this, what is the recommended guidelines around alcohol. Matter of fact, let me ask you folks, what are the recommended guidelines for alcohol? And you could use gender-specific information. Tiffany?
No drinking and driving.
That's a good guideline. So do you know, all right, so do you or anyone else here know also the recommended drinking guidelines, Julianne?
I believe for women, it's no more than 7 drinks per week.
Mhm. That's correct. So not to exceed 7 in a week. So, and it'll be in the slides, but, oh, it's Tiffany, you still have your hand up. Do you want to add more?
I'm sorry.
No, that's okay. So typically, not more than, oh, I see another hand. Jolene, did I say correct?
You did, thank you.
Okay, cool.
Is for men is 2 drinks or less in a day, and for women it's 1 drink or less in a day.
Right, and then not to exceed the 7 in a week for cisgender women, not to exceed 14 in a week for cisgender men. And Wes, thank you for that. And unfortunately, it does use a binary perspective to provide these guidelines, but we have something for you to, we do have something for you to consider in terms of if you're working with a gender diverse person or transgender person, how might you bring it up? We have that here too. So that was really good. Thank you so much for that. People who binge drink are 4 times more likely to use other substances than people who do not drink. How about that question? Does anyone know what binge drinking is? Okay, so then I'm gonna wait on that and give you that explanation a little later because it's gonna tie into everything we're talking about here. So substance use in youth and young adults. So that's another trajectory looking at this particular population from that perspective. Over 133 million people who drank alcohol, 45% were binge drinking. Out of all of that, it was higher amongst individuals between 18 and 25 years of age. And for individuals who are still developing, and development, a fully developed brain is typically anywhere between 25 and 30 years. There's a lot of different data discerning speaking to a wider range of a fully developed brain. So what's interesting here is that this is an ideal conditions, and when ideal conditions meaning have healthy options and their environment is healthy and they have appropriate nurturing and so on. And so we want to understand that we're working with folks within that age community. Then we want to understand what are the other issues I may present that might actually, kind of cause this to look a little different. So around those folks who were up to 20 years of age in 2021, more than 15% were past alcohol users, and 4% of those folks were adolescents between the ages of 12 and 17. And so underage drinking in the past month, and this is according to, these are just patterns because research and data gathering sources and initiatives tend to gather enough to reflect the pattern, but does not necessarily give you an accurate number because not everyone is involved in the study, not everyone is responding to questions, but it gives you a good idea that there's a huge amount of folks who are binge drinking. More than 8% of people binge drink, and 1.5% are actually heavy alcohol users. Over half of the LGBT youth, 56% used alcohol in the last year, 47% were under the age of 21. Now, one more trajectory that I want to make mention of, risky and harmful consumption. And because we've seen that a lot of folks have been using opioids or have been using alcohol or some type of psychoactive substance in the last year, we want to understand what harmful consumption is. So more than 9 million people over 12 years of age misuse opioids in the past year. They're using it other than directed. And so 9%, more than 9 million people actually misuse pain relievers. And when I think about pain relievers, it's not just folks who have had some chronic health issue. but it really speaks to also, like, I'm thinking about the older adults. When I think about older adults and the fact that they're more likely to have 3 to 5 medications, that they have to prescribe medication that they have to work with. There is a good amount of folks who may be misusing for a variety of different reasons. For every one person, this is important, for every one person who has a substance use disorder, there's a 6 or more who are consuming at risk levels and impacting their health, their psychosocial environment, or their relationships, but it's affecting them and they're not necessarily aware. And most of us, our focus is almost always on the person with a substance use disorder. So what is SBIRT? Let's break it down. SBIRT's first component is the substance use screen, the screening process. Now, SBIRT as a model can be applied to a lot of different types of risky behavior. For our purposes, we're going to talk about substance use because that's where it was first deemed evidence-based when it was empirically researched and replicated within the healthcare setting. But this model is also applicable in other non-healthcare settings. So I won't say it's evidence-based there. The literature shows that it's evidence-based within healthcare communities, but that's how effective this model is. So the first component is screening. It's about facilitating universal screening for assessing quickly the potential severity of any illicit substance use. The brief intervention, which is a really great approach, because it's very effective, it's very person-centered. It's about having a brief dialogue, a brief conversation where you raise the person's awareness around the intersecting risky behavior and current impact of certain challenges that they're going through. And so it's really about raising their awareness about their risky problem use, substance use. Referral to treatment. Remember I was saying before about specific terminology. This component has always been labeled as referral to treatment. What it is referral for further assessment. When this model was first created, the recovery-oriented language that had not evolved and had not been applied. And so referral for further assessment is really what this model ends up being. And I'll explain to you a little bit more, because there are some folks that may score high on a screening score, and it may be that they have a substance use disorder, but without an assessment and a diagnostic process, you really can't indicate that it is. And so we want to refer out to the appropriate resources to be able to do that. So we'll talk about that. So why is SBIRT important? Give you a few quick reasons. Excessive alcohol consumption contributes to 140,000 deaths, and that's every single year. And now what I'm going to add to there is that the 140,000 deaths that are preventable. The costs to society are more than 249 billion for alcohol misuse and 193 billion for illicit drug use. And that's on an annual basis. And these numbers are likely higher now. And this comes from a 2023 resource, but it's probably an estimate. And like most research and many data sources, they tend to provide you what should I say, a quick glimpse, but not the accurate. They usually represent the actual numbers. So effects of unhealthy and unsafe school and drug use have far-reaching implications. So it's not just the people that we want to serve. It's also their community, their family, their workplace, everyone else who's associated with them and within the healthcare system. And so substance use has consequences. It has, injury from trauma, criminal justice involvement, chronic health conditions, social problems, mental health consequences, increased absenteeism, accidents of work. What might you say, other than those that I just mentioned here? What are the consequences have you seen that substance use has in terms of the folks that you've provided services to? What might be another example that you may want to add to this list?
Hi, I was going to say incarceration.
Incarceration.
That also costs a lot of money.
Yeah, incarceration, being criminal justice involved. And so a lot of that will come back into the public sector and impact that community. Latoya, thank you for that. Latoya?
Yes, hi. What I've noticed in my experience is how the impact that it has on relationships, even especially those that are romantic. Sometimes having a partner who is using a substance, that may hinder one's ability to become sober or to remain sober or to find themselves back in a cycle of just, how do you say, like pretty much, I can't think of the word right now, but I think like when they're back in a cycle of coming back to a relapse, that's what it is. I've had that in experiences. And then in some cases, it can affect a relationship in terms of the person's use pretty much affecting how they communicate with their partner, or it may lead to money issues and things of that nature.
Thank you for that, Latoya. And I'm going to say that that has a nice connection with what Terrence, what I think you were trying to say, what you put in the chat box, being about referring to family dysfunction, relationships, association, and how people interact with one another. So thank you for that. Hi, Carolyn.
Hi, Diane.
What have you seen?
Well, I've seen the breakdown of families, support systems, and we've been talking about relationships. Everybody is talking about it, but just the overall breakdown of families, parents are kind of separated from their loved ones, husbands, wives, children. So there's a dynamic where a family breakdown happens when there this disorder, going on in families.
Yeah, behavior changes when there's a lot of consumption to a degree that it affects relationships. The focus is different, the interactions, the tones, and so much more. I'm also going to look at so thank you for that. So I'm also going to look at one of the more commonly mentioned aspects in the chat box, which I do a lot of work around, is the trauma. And sometimes for a lot of different reasons, it can be a coping mechanism for folks with trauma. And we know trauma and stress is just so prevalent with all the communities, and just in general in our world, whether someone's your client or can benefit from treatment or not. So trauma and stress are pretty high. And so, but it can also have an effect on someone's traumatic responses, because trauma itself is more of a physical response and it's a neurological in basis, and the physical responses can be impacted by how somebody might want to mitigate some of those symptoms in themselves by drinking. And just as one example, but I see trauma, incarceration, impact on children and family, impacts to the community. All right, so thank you for that. I'm going to go back to here. Consequences of substance use. And so I just want you to consider this. This is intentionally titled rather like this: substance use. Not substance use disorder, substance use consequences. Consumption of substances at varying degrees, depending on the person, dynamics and circumstances, it can impact individuals in a lot of different ways. So here's the thing. Now, if it wasn't you folks who work in the field, most of the community at large, society at large, tends to look at substance use from a binary perspective. So either from prevention, where substance use services have always tried to preclude or delay the onset of substance use, or the other side of it. Like many of us are very familiar with the fact that treatment, that either someone can learn how to avoid the potential risks associated with substance use, or they have a problem and they probably can use help. And so providing time and cost and labor intensive care to persons who are either acutely or chronically ill with a substance use disorder. And so I want to look at it a little differently. I want to give you a visual of this. So let's just look at this line as if it were the progression of substance use. So the traditional perspective, community perspective on substance use has always looked at, when somebody can handle a drink, and or they're not drinking at all, or they can use responsibly. So they're able to hold jobs, be able to have healthy relationships with family members and other people in their lives. It doesn't affect anything in their lives. They're able to achieve goals and so on. And then the other perspective that society tends to have is that, well, if you can't handle a drink, you probably have a problem, and maybe you can benefit from some services. So it's like this binary perspective that either you're okay or you're completely overboard. And so the thing with SBIRT is it says a new initiative that has been there for a long time from the original developers of this content, but I would say it's a not so new initiative. Substance use screening, brief intervention, referral to treatment is a systems change initiative. And so we're thinking of, engaging in a shift in our view. And so we want to look at substance use a little differently and understand it, reconceptualize it. We want to redefine how we identify it and how we approach, address, or treat substance use problems. And so what about using a public health approach? How does SBIRT fit into that particular perspective? Well, let's look at it like this. Substance use is a public health problem. If we think about how it affects an individual, we want to consider certain different things. Right here, I have this terminology here before I can move on. And in order to talk about substance use, you want to be very specific of the terminology. So if I ask you folks, this is the question, and I'm going to come out of here. What's the difference between substance abuse and substance use disorder? Those two terms. What's the difference? Anyone care to?
One, I guess substance use disorder could be chronic, while substance use might just be a one-time or an acute thing.
Okay, chronic or acute. Thank you for that. Adam, hi.
Hi, sorry, I'm not very good with the buttons and things of that nature.
That's fine.
So substance use is by definition utilizing the substance in an inappropriate manner in a way that it's not recommended, et cetera, and so forth. So if you're using an illegal substance or a substance that's not prescribed to you, et cetera, and so forth, that's substance abuse, right? In theory, if you're using more alcohol than what you're supposed to, that's substance abuse. Substance use disorder not only has to meet the criteria for utilizing a substance that is being inappropriately used, but also has to meet the criteria for the DSM diagnostic criteria for, whether it's impeding you in your existence, whether it's affecting your relationships, like all those different criteria. It has to be going on for a certain amount of time, et cetera, and so forth. There has to have been attempts to stop, like all those different bits and pieces that we have in diagnostic criteria to be determined to be a substance use disorder. Substance use is just substance abuse is just substance abuse, right? You used a substance inappropriately, but substance use disorder has to meet that criteria.
Well, thank you for mentioning the criteria and the DSM. And so, yeah, there's a clinical protocol involved in the assessment and diagnosing of substance use disorder. So substance use disorder is the term we use today. We're not encouraged to use substance abuse, no matter how long we've been around, because the terminology, again, has evolved. So let me just tell you what happens. So thank you for that, Adam. And substance abuse is often defined the way Adam just described it, where someone's using it out of, the way it's out of the manner it's supposed to be used. The problem with substance abuse, and this is how I'm going to frame it, is for many years, and I've been in the field, I don't know, for more than 25 years. Some of you folks have been here longer, the same or less. But substance abuse was this common terminology that we were trained on, we were educated on, and it didn't meet at that time. And the other DSMs, the third, the fourth, the other versions, the DSM did identify substance abuse and dependence as a particular category, as a particular condition. What's happened over time, that seems to happen with all kinds of terms and all kinds of words that we use, is that over time, because some words pick up negative connotations because the lack of information or the ignorance from the field or the communities, or not understanding how substance use actually works, what happens, so the science behind it, not just the behavioral the behavioral indicators that we tend to see and tend to interpret for ourselves, which isn't subjective on its own. What happens with substance abuse is over time, it has been looked upon. It has given it a negative connotation. It's like saying that someone is willfully using substances out of their choice, other than how it's supposed to be done. whether whether we're talking about prescription medications, whether we're talking about alcohol, or even illicit drugs. And so even though we as providers knew, understood what the meaning, how it's defined for our work, we also understood after a while, what we got from the communities themselves is that it ended up being stigmatic. So when someone from the community hears substance abuse, it's like they're being judged. It's like that can be like it's a willful act on their part. And one of the things about addiction is that the neurological processes, that reward pathway, that gets revamped, that gets rewired, with substances. It's not like the person necessarily has the capacity to stop using even if they wanted to. There's a whole science behind it. So substance abuse ended up being a term that for a lot of people in the community tends to judge them. And so it kind of neglects, it kind of omits that the science of how addiction works. So now the DSM-5 has been saying substance use disorder. You don't find substance abuse in the DSM-5, and that's the terminology that's been out since 2013. So we're encouraged to use that. The reason I bring it up is because it helps us as providers to evolve our terminology, because when it comes to this particular model, especially, and it should be in all aspects of work, but in this particular model, it is going to speak to how it translates in your conversation with an individual. It's going to speak on how it translates when you want to facilitate a substance use screen. It's going to speak to how it translates in inviting someone in a conversation. Why? Because if we use substance abuse, what can happen is that person may not want to get in a conversation. That person may not come back and visit us. And then we lose the opportunity to provide support. So in this particular slide, and so thanks for that. And a lot of people see it that way, where someone is using substances out of context or out of how they are supposed to be used. So these are the different levels of use. So the public sees the binary perspective of substance use as either someone can handle a drink or not drink at all, or if someone has a problem, should go to treatment. And so substance use here is, like Adam says, it's just the consumption of any psychoactive substance. Whether it's legal or illegal, it's not the issue. It's the fact that a substance that someone is ingesting or taking in somehow has a psychoactive property to it. Substance misuse is the inappropriate use of prescribed legal or illicit substances. That's what we have right now. So that's what substance abuse had really evolved to, is the misuse now. And so what it tends to, and that one tends to come from the NIAAA, National Institute on Alcohol Abuse and Alcoholism. And so they're the folks where we get the information and the research from that kind of indicates, it's illegal driving levels, what happens to the body with alcohol. So substance misuse is the inappropriate use of prescribed legal illicit substances. So that has to do with binge drinking. It has to do with taking medications other than prescribed. Risky substance use, and I've referred to this before, is consuming at levels that can be harmful or hazardous to a person's health. So someone who's drinking more than the recommended guidelines, or maybe having, or even not even more than recommended guidelines, maybe have some health issues where one drink can be harmful. And so health-related issues can come up when someone is consuming at this level. It doesn't mean that they'll meet the criteria of substance use disorder, but then it may exacerbate mental health issues. It may impact relationships. It may impact someone's outcomes in terms of the work performed at the job. So this is what a lot of folks don't see, because we're so used to understanding that we do prevention, or we work with people who have a use disorder. And so substance use disorder, as Adam said, meets a particular criteria. So this is, it's cognitive, behaviors, physiological. It has to do with, if you look at the criteria, there's 11 points. So 2 or more is all that's needed. 2 or more, at least 2 of them need to be met in order for someone to be diagnosed with a particular disorder. In terms of this, we're referring to substance use disorder. So these are terms that are going to be very relevant to facilitating SBIRT. And so it also helps us to kind of evolve or enhance our understanding of the practice, not just the substance, how substance use works, but the practice, how it translates in practice. So let's think about substance use from a public health perspective. Here are the folks who are substance use disorder. These are for folks who are working or used to work in treatment. these are the folks on the left who have a substance use disorder. These are the 2 to 2.5 million people a year that actually get into treatment. Now I put, and one of the things that I included in the text is that 4 to 6 people per person who has a substance use disorder are consuming at-risk levels or are binge drinkers, and that's represented on the right-hand side. And so even though this is what we have been are accustomed to looking and working with substance use disorder, from a prevention perspective especially, we can work with folks who are binge drinkers and at risk, but we aren't always targeting this level of behavior or this level of consumption in our work. And so what we want to do is learn from a public health approach. So the public health system, let's think about this. So public health usually, screens for potential medical problems, and it's a preventive approach to try to prevent, to try to avoid the onset of acute symptoms in a person, or delays or precludes the development of chronic conditions. And that's especially important. So here I will give you an example. And so I would tell you, so in my world, so one of the habits that I have with my guy, which is a really cool habit, and we've been doing this for more than, going on 21, 22 years, something like that. Every morning we get up. The ritual in my world and where my guy is, we get up in the mornings and he makes the coffee. I can't make coffee. So he makes the coffee, we meet together, we have coffee together. And we take the few minutes to kind of keep a nice mellow energy before our world gets taken over by the rest of the day. And so we have this habit every single day. One day we were sitting down having coffee, and I look at him and he starts to struggle, and his right arm is grabbing his chest. And I said, "Are you having a hard time with your chest?" He says, and of course I'm asking him to speak, and he's obviously having a hard time even doing that. And he's saying his chest is tightening up and he can't move his left arm. So what do you think I thought at that moment?
A heart attack.
Heart attack and stroke.
I said, uh-oh. I said heart attack. I thought about heart attack. So let me just tell you why statistics and why I'm geeky over statistics and research. So this research shows that 55 that people over 55, particularly men of color, and he's a person of color, men over 55 are in the highest risk for a cardiac arrest. So that statistic came up instantly, and so I knew right there and then that he needed to go to the hospital. And so we ended up going into, I called EMS. I didn't want to drive, and so we went together, and they were asking questions about history. They were checking his pulse. They were checking all his vitals. And then of course, and then when we got to the hospital, he went straight into care, and I stayed behind, insurance and all that other stuff. So that type of approach, public health approach, folks do that. The healthcare community does that to try to prevent, to try to avoid, a potential lethal outcome. So what they want to do is that preventive approach was supposed to be able to just find out some details, to assess them very quickly and make some decisions around trying to prevent him from dying. Basically what it is. So I'll say it straight out. Now, that's a public health approach. That is what we're going to conceptually involve and use with SBIRT. I will tell you that the end of the story is he ended up, what he was having some very, very, very severe gastric issues that actually mimicked those same symptoms of a potential heart attack. So even then, that was a helpful thing, because it didn't have to be that. It could have been that he had that his family history had indicated, cardiac issues, or maybe heart attacks in other family members, and it would have avoided a potential potential death. And so that concept, and so I'm very grateful. I think, what was he left? He left without I think he left without a gallbladder. So they kept him for that. So what happens, but he hasn't had that ever since. That was a while ago. And so what we are trying to understand here is that approach to prevention, including prevention in our work is so helpful. So that preventive approach is what we want to use in SBIRT. And so another visual of that is this. So that's the progression. That's the progression of substance use. Abstinence, experimental use, maybe social use, maybe binge use, misuse, substance use disorder. There's a progression. If someone starts to consume, drink, indulge, and they're at this point of the spectrum, that's typical of most Americans in this country. The idea here is this, that the binary perspective that society sees, that either you can handle a drink or you need help, is there, but we want to understand there's a lot of other folks for a lot of the folks that can also benefit from our help. So the binge use and misuse is something that we can help address. What is the benefit of helping address something there in terms of when you engage with a potential patient or a client?
I believe at that time some changes can be made.
Yeah, I think I believe that as much. Substance use disorder, someone is at a point where that brain is at a point where it may need interventions and support. Joanne?
Yeah. As I say, it's a great time to intervene. Because folks often don't even understand or see the progression that they're involved in until they're at the end, right? I always say no one picks up drinks and thinks they're going to become an alcoholic, or smokes weed and thinks they're become addicted. But if someone can intervene in those middle stages and help identify the person, that I'm not saying this could happen. I'm not saying it will happen, but this can happen. So let's talk about what's going on with you and how your, the social determinants of health, your environment, what else is going on with you that could play a part in this, that could lead to a substance use disorder.
Thank you, Joanne. That was very well articulated. I like the fact you say that you're not saying that it will, but that it can. So important. Julianne.
It can prevent secondary impacts like job loss or, issues with relationships that can just make everything worse.
That too, yes, I totally agree with that. And thank you, Terrence, also bringing awareness to the client about the harm associated with substance use. Meg, I suggest with you folks, and you could think about this, if you're familiar with what happens when someone has a substance use disorder, if you're familiar with how those neurotransmitters are so, are really part, not the neurotransmitters, I would say the midbrain, the limbic system is foundational to that drug-seeking behavior of keeping that process on, and how that reward system gets rewired by the chronic use of substances. Where someone meets a substance use disorder, it's also the hardest time for folks to, even if someone wants to not use and wants to stop right there, it's also a time where they will have the hardest time following through with themselves. And so it's amazingly challenging for someone to do it on their own. And it might be very hard for some folks at that time, because of the rewired cognitive processes, for them to actually be able to process a conversation with you as effectively as they could be when someone's misusing or binge use or over consuming levels here at risk levels and binge use and misuse. So you can still have a conversation with someone at that point, and it may be easier for them to actually consider changing behavior. It's a lot easier to do it here than it is at a substance use disorder level. And so without other dynamics getting involved, so this is another advantage. Okay. And so there's so many opportunities. So we want to see this a little differently. We want to understand that prevention is one thing, but it's also about not understanding, very much like Joanne was saying, not everybody who is at a binge use or at a risky level of consumption is going to end up having a substance use disorder. There's no indicator that, there's no behavioral indicators that specifically dictate who will have a substance use disorder. It puts people at higher risk, of being in that, eventually being in that category, it does not necessarily mean they will be. There are plenty of people who are consuming at at-risk levels who still keep a job, who still are able to keep their families, but may have some health issues, but can have a conversation. And so that's what we're focusing here on SBIRT. And so the primary goal, and that speaks to it. The primary goal is, can everyone hear me now? I think I lost your signal. I lost signal for a moment. The primary goal of SBIRT is to identify and effectively intervene with those who are at moderate or high risk. Into that first goal, the primary goal of SBIRT is to help work with those folks, those who are at risk levels for psychosocial healthcare problems related to the level of consumption. That is the first goal. It also does help to identify people with potential substance use disorder, but that's not the purpose or the initial goal of this SBIRT process. But if we come across with high scores of on the screening instruments, then we understand we can have a process in place to also help those folks too. So it's really important to understand that the focus is broader than what it used to be like. So the research demonstrates effectiveness. There are different research that has shown its efficacy with the youth population. That's a craft tool there. I'm going to show you a few tools. I'm not going to go into it deep, but I'm going to show you different validated tools. In order for this screening component to work, and you have to use a validated instrument, not components of validated or evidence-based instruments, just one validated instrument working with that score. Brief interventions conducted in emergency rooms have shown a reduction in alcohol use and have seen that folks are having repeated the visits to the emergency room due or related to their consumption. So brief interventions that focus on alcohol, prescription medication misuse have been found to be effective also for the adult community. And so the key here, and really important, and I can't stress this enough, and I'm a big stickler for this, and I've been doing this for a while, and I've seen that there's such a difference in how we as providers might get caught up in our protocols and our routines. And so the key here is fidelity. Fidelity refers to the degree of practice as delivered or intended or designed. If we deviate, fidelity is usually, if we deviate from fidelity, the outcomes are not typically, they're not as a result of the model, it's typically a result of some kind of deviation on the provider's part. So being strict and conserving the original model components and processes can directly impact the success of desired outcomes. Now I frame it with a cultural lens, with a stigma-free lens. I could frame it with the perspective that this will be a person-centered approach, but we won't change the model. The model still works effectively on its own. So the primary focus of intervention fidelity strategies is on the interventionists themselves. And so how much we stick to how this is designed to work is going to increase your outcomes. And we see that, in different SBIRT settings, and you'll have this in your slides, this is applicable and integratable in a lot of different settings other than healthcare communities. In New Jersey, there's a legislation that requires that those three components are built into this education system. It's not that way in New York, but we do have those components, and it's not endorsing SBIRT, but because it is endorsing those three components, we have seen, and not just here, and not just in New Jersey, but we have seen, and in pilot programs in New York, but we've also seen across the country that in the school setting, it has provided an opportunity to be able to intervene with youth. And so there's a variety of other settings that this can be applied. So the idea with SBIRT, it uses a pre-screening, a universal screening aspect. We'll talk about that. A full screening with a positive, for those with a positive pre-screen. So understanding scoring is really important. A brief intervention, an extended brief intervention. Sometimes you need to sit more than one time with someone. Specialty treatment for those who have a probable substance use disorder. It's all potential, and the wording should say as much. Right now, let me stop to share. Any comments, any questions about what I just presented? Because a lot of it you knew, I'm adding other layers to it. Does it make sense so far? Oh, done. All righty.
You got a lot of substances out there right now that just became legal that was formerly illegal.
Mhm.
You know, and a lot of legalized prescription substances legal
Right.
now. So when you talk about the format and the guidelines and the model for SBIRT, I'm trying to figure out, well, is the individual going to abuse it, or he's using it for medical purposes or whatever? You know, where does that fit in with SBIRT in so much as, for instance, marijuana? Marijuana now is being, you know, consumed for medical reasons. You know, it might lead to something else, but, you know, that's what I guess SBIRT is trying to say, you know, on the model scale that you produce. But I'm trying to figure out, you know, where we fit that in with these drugs or substances, as we call it right now, that are now used for specific medical treatment. You know, I mean, it's attaining the same objective that the individual might want to get, you know, with things like Oxycontin, you know, or something like that, you know. But I'm trying to get to the nexus of the fact of the goals of SBIRT to imagine the goals and the scales of how it's being used now in case an individual has understanding that, well, you know, I'm really using something I should be using anyway because I need it. You know, to us, you know, or clinicians or whatever we call ourselves, saying that, well, this can lead into overwhelming abuse or, you know, other things on the SBIRT scale. Now, I would like to know, you know, what do you think about that and how it's being used on the scale of SBIRT, you know, when actually MDs is prescribing stuff, a lot of stuff that we call, you know, substances that are breaking over, you know, causing other damages to individuals we serve.
Well, thank you for that. So I think Alfred, was that Alfred? Okay,
Yes.
thank you, Alfred. Because I can't see you. I want to remove myself from the spotlight and just be in the screen, but I'm not sure if Clyde's gonna let me. But what I want to say is the goal of this SBIRT is exactly what you're talking about. So I don't use the word abuse. I use over consuming. I use at-risk levels because that helps my mind think in that way, where it might be a health approach so I can help that individual from that perspective. I'm not thinking that someone is intentionally trying to use something out of context. Almost always there's a reason. Like for instance, if someone is using, someone has used Percocets after a surgical procedure, maybe it was more of one of those one-day surgeries and you're home the same day. Maybe it's a knee, and let me tell you, a knee surgery. Let's do a knee surgery. Maybe they're cleaning up, you know, the joints and trying to minimize the arthritic pain. And they were given some hydrocodone to maybe deal with some of the pain. Well, what that does is help in the moment. It's used as prescribed. Now, that same person, this is just a potential scenario. This is totally fictional. But let's just say that same person, okay, still has some Percocets, only used it when they needed it and left it alone, you know, maybe once or twice, or maybe not even, or maybe once, or maybe not even at all, left it there. Let's say they did use it once, excuse me, because that's the point of my story is this. At some point, maybe there's some kind of hardship, maybe there comes some kind of stresses, some kind of pain that's not necessarily the kind of situation they go to the doctor for, or maybe they're overwhelmed, distressed for a long time. I think what tends to happen with a lot of folks, at least the folks that I've worked with, is they'll remember that when they took a Percocet, not only did it take the physical pain away, it gave them a little bit of a break from where things were not as stressful and as intense in their lives. So to actually cope and mitigate the stressors of particular situations. So the person is not necessarily using it to get high, but maybe using it as a coping approach or coping mechanism to deal with a situation that they need time to kind of revamp or reprieve themselves or, you know, regenerate their energy so they can go back to dealing with a situation. What happens with that also is that people remember those benefits and use it in different ways outside of how it's prescribed, not necessarily thinking, oh, I'm gonna have a substance use disorder, I'm putting myself at risk, not necessarily thinking that because they're still being responsible, they're still taking care of their business, they had an actual reason in their minds as to why they use it. That is one of a million different scenarios why people might be consuming more other than how it's prescribed, and not necessarily understand how they can get caught up in a substance use disorder eventually, because they don't necessarily have that information. They don't necessarily have, sometimes labels might say it can be addictive. It doesn't mean that it says addiction means or substance use disorder means so on and so forth. It doesn't come very specifically prescribed. And it kind of is dependent, I believe, on not just on the health practitioners that prescribe, but all of us who provide any kind of service to that individual, to give them that extra information that doesn't normally come with a prescription bottle. So that's just an example of how sometimes folks might find themselves consuming and overusing or using outside of instructions to deal with different situations. Not being aware of the what you folks are aware of, which is the criteria, substance use disorder, and things like that. And so this is why SBIRT can be such a critical approach and so essential to most communities and most settings to be able to address those issues, because you get the opportunity to kind of bring insight, increase their awareness around that potential association between their risk behavior and some of the issues that may be happening with them and their eventual goals. You're able to do that. And when we get to a brief intervention, I'll talk to you about that. So keep an open mind, and just bear with me for a little bit so I can clear that up for you. Okay, Alfredo?
Gotcha.
When we integrate this and facilitate this whole model with a given person, it should look different from one person to another. But you need these components in place in order to be able to tailor the approach. And so screening for substance use in your practice setting is very specific. Substance use screen has its benefits. So why do we screen universally? It's because early identification and intervention lead to better outcomes. This is something that's age-old knowledge. We do know that. It's also, you can put your answers as to in the chat box as to why we are screening universally and how we define that. And so we also know that one of the things that, and I didn't speak to it specifically, but it is in your handouts, is that any over-consuming any psychoactive substance can actually influence or impact your motor skills. And so, injuries can be had. So we know, I think it was Tiffany that said, don't drink and drive. Makes perfect sense. Don't use any kind of psychoactive substance and drive. It can impact it, or it can impact your ability to drive carefully or appropriately, or it can exacerbate existing issues that a person may be experiencing. It's also a good opportunity to intervene and educate about the at-risk levels of consumption. And so I think you also want to consider that when we screen universally, we pretty much prevent folks anyone from falling through the cracks. There's still some settings across the country that provide certain screening with certain folks and certain other types of screening with other folks, and don't necessarily screen universally. And so we don't want to miss an opportunity. So substance use is not an obvious process. It can be very, very elusive. Any person can look any kind of way and have an issue with risky behavior, with risky levels of consumption, and we may not just pick out it just because we see it. And so that's not the way our process is working out. We also know that 90% of substance use disorders that don't get identified and don't get treated because they're not even screened. And so being able to just screen everyone and not targeting anyone and not isolating any one community is helpful for effective practice. So based on findings of screenings for findings of audit screening, so this is from the alcohol screening instrument, what tends to be found is that when you facilitate universal screening in your settings, a good 75% of folks don't have any risks that are identified. And so SBIRT tends to be practiced in any non-substance use disorder treatment setting. And so 75% of these folks are likely not going to show a positive result for an alcohol use disorder or a substance use problem. there's a good 20% that tend to score at a level that puts them at risky, at harmful or hazardous consumption. And there's only a 5% of the population that will indicate that there may be a probable substance use disorder or an alcohol use disorder, stimulant use disorder of some kind. And even though we are used to seeing a lot of the folks in the 5%, there's at least 20% of folks who are at risk who can use our help. And these screenings, when you screen universally, tend to identify who these folks can potentially be. And so every year or every few years, this gets updated. The National Institute Alcohol Abuse and Alcoholism, NIAAA tends to include their recommendations for drinking and the dietary guidelines for Americans. The most recent one is 2020 to 2025. It speaking to, I believe it was Joanne who said it, 1 drink per day for women of legal drinking age. Actually, we had said it was two drinks per day, up to 3 drinks per day. And so it's being reframed very differently. 1 drink per day for women of legal drinking age. It should be cisgender women of legal drinking age, not to exceed 7 in a week. Up to 2 drinks per day for cisgender men, not to exceed 14 in a week. And this has a lot to do with how biologically the body works, because there tends to be more water and ethanol, water and enzymes that break down ethanol and more in the average male body than there is in the average female body. So binge drinking, what is binge drinking? It's a pattern of drinking that brings blood alcohol concentration to 0.08%. For many years, it was 0.05%. So it typically occurs after 4 drinks for women at any one time, any one sitting, or 5 drinks for men at any one sitting within a couple of hours. I would dare say that it's even less for that, because depending on the person. And so what it is if you think about it, a standard drink gets processed or metabolized, takes a good hour for a standard drink to get processed. And so if you're having 2, 3, or 4 drinks in one sitting and within a couple of hours, your blood alcohol level is going to increase. So heavy alcohol use is defined as those 4 more drinks in any one day for men and 3 more drinks for women. And again, this should be cisgender men and cisgender women, and that's on a consistent basis. And so binge drinking, but when you're having a conversation with somebody, whether it's binge drinking or something else, that person is not necessarily understanding that kind of terminology. What you want to do is understand how that's going to translate in a conversation with the individual. But when screening is really helpful to clarify what 1 drink is. And this is not so weird that 1 drink may be this huge glass. I used to have clients that when I was working in prevention, where I would work with them and have dialogues around harm reduction methods around how to reduce drinking that's impacting their health. And a lot of times someone might say, they have a drink for them is a 32 ounce of Old English. I don't even know if they make that beer anymore. And that was 1 drink. So actually understanding the perspective of your client or the person you provided services to is an important part of having that conversation with someone. Got to get their perspective so you can tailor the conversation. And so a standard drink is typically this. So 12 ounces of regular beer, malt liquor. Like say if someone just drinks a couple of cans of beer, every other day, a couple of times a week, that will be one thing. But then if you start to understand in the conversation that they're on weekends or whenever they go out to a place, they might go to maybe a restaurant bar. Restaurant bars don't tend to serve cans of beer. They tend to serve beer in large vessels. So here you have even more that a person may be consuming, but may be perceived as 1 drink. So understanding those details from someone's life and their when they do drink, when they do consume, it's especially important to tailor conversation with an individual. And so the one thing I want to mention, I want to make sure screening does not provide a diagnosis. And so because screening doesn't provide a diagnosis, our language has to reflect what we're doing. And so, and I'll talk to you a little bit more about that. And so this is here, let me show you substance use screening instruments. What you want to understand is when someone is facilitated, when the substance use screening instrument is done, it should have a score and an interpretation. So there's some pre-screening tools that many organizations use. And that's all this is just a few questions. Often it's incorporated within the intake process. It's a few questions that if they indicate a particular score might be a reason to actually facilitate the full screener. A lot of screens that I'm going to show you now have like 10 questions, maybe more questions, but the idea is what would be the most feasible to do for a new patient or a new client. And so screeners can identify folks that you may need to explore further about their potential consumption. And so these are some instruments, and these are on the New York State OASIS website, and the link is provided to you. And so for adults, the alcohol use disorder identification test, the audit tool, the DAS, the assist, even the single questions of pre-screens for NIAAA and NIDA are effective screens. These are considered validated screening instruments. That means when they are facilitated the way they are designed, they are accurate almost 90% of the time, most times. So they have a high, no, let me say it differently because each instrument is different. They have a very high successful accuracy of on that tool. And so this is youth. We don't use dumbed down versions of adult instruments for youth. We use very specifically designed instruments with youth. There's also some for older adults, there's some for pregnant women. Interesting thing about older adults, to do a lot of work around that too. Older adults, when age degeneration issues were not necessarily considered when those recommended drinking guidelines were developed. And so according, New York State OASIS has taken a stance that the recommended guidelines for cisgender women are also applicable for persons over 65. And so because of how the slower metabolism and how long alcohol or other substances might stay in the system. And so this is one example of one maybe more simpler screening tool. So can I have a volunteer to read the first 4 questions, please? Debbie, thank you.
1, have you ever felt you ought to cut down on your drinking or drug use? 2, have people annoyed you by criticizing your drinking or drug use? 3, have you felt bad or guilty about your drinking or drug use? 4, have you ever had a drink or use drugs first thing in the morning to steady your nerves or get rid of the hangover?
Thank you, Debbie. And so here's the interesting thing about these type of questions. These questions can be like less intrusive than some other questions, but no matter what questions you ask, it's really about actually asking them verbatim. So these questions have been tested over and over again. Tiffany, go ahead. What's your question?
I don't really have a question. I have a statement.
Sure.
Number 4, have you ever had a drink, use drugs first thing in the morning to steady your nerves or hangover? Now, that's an interesting question because it's like at one side of it is, yes, you're asking the individual who's using these substance use or alcohol, but at the same time, when I heard that question, it just brought me back to a place where just people in general will train you to use these things for your nerves or for hangover, like, and next thing you know, you become addicted, you know?
Before I respond, Joanne, go ahead.
We have to think of it, if I understood the first woman who was talking correctly, I think it was Tiffany, but I'm not positive. Forgive me for that. Times change, our knowledge changes about substances. So it makes me think about a childhood friend of mine who's mother, when she was in labor and delivery, she would always tell this story. That was the first time that she started smoking. And it was the nurse who provided her with a pack of cigarettes to pass the time. You have a hangover, the best cure is to have another drink. We have more knowledge. That's not to say that it's still not going to happen, but we have knowledge now that we can kind of counterbalance that with other individuals. So that's all.
Thank you. Thank you, Joanne. Debbie.
Those 4 questions with what Tiffany said, those 4 questions, when I was, the third one, have you ever felt guilty about your drinking? I think when I was drinking, but in other ways too, we all had times of, not we all, that's inclusive bad language, but there were times when I was drinking, like, oh shit, I drank too much last night. I mean, these questions are like very random in general. They're very, they're very misleading in some ways, I think. Because I think there are times that I feel that many people could feel guilty about what they did over drinking for the night before. That's how I feel.
Okay. All right. Thank you, Debbie. Julianne?
Yeah, thanks. I think kind of similar to what Debbie was saying, I'm curious if you could speak about the use of the word ever in these, because to me, I'm thinking about like, what if it was 30 years ago, you know? And then the answer is still yes. So I'm just curious how to navigate that.
Well, here's the thing. And this particular screening tool, this particular one, those 4 questions exactly as they're written, it was was asked verbatim, and they were able to aggregate the data in terms of the outcomes, how the responses. And these generated a particular score. And so these particular questions, as opposed to maybe quantitative questions, are together spoke to like some of the things that happened when some folks may indulge. This ended up being, this was put together as a tool, was replicated, was considered validated. And what happens is they ended up having a scoring system that and a scoring system that did help identify people who were at risk or people with a potential need for further assessment. And so this helped to start to identify whether or not screening scores, substance use screening tools are to identify a potential issue to explore with an individual. That's what screening tools are for. They don't diagnose, they don't do anything else, but they do let you know that, okay, there may be a potential issue. Let's explore this a bit and let's find out. So this is only one. The researchers who used this cage aid, what ended up being cage aid, ended up having a scoring system with very high accuracy. Because the more the conversation was, it started to identify other issues on the follow-up of this, the more they were able to see that this did pick up on potential issues with people. This is not the only tool. So I understand you may have different feelings about this. I think this is specifically asked within the context of the last 12 months. And so, but this is not the only tool. This is another tool. This is one tool that might seem less technical for some folks. It might be a preference. The ones that are used the most often is the audit, but it's also the DAS. The DAS uses questions like this too. Have you used drugs other than those required medical reasons? Yes or no? Then you tally it up. The idea here is no matter which validated instrument is used, in order to do SBIRT effectively, you have to use a validated instrument, an instrument that gives you a score and an interpretation of that score. So the DAS is one of them. Here are the scores. One of the nice things about DAS is it provides you the risk level. If someone scores within any of these numbers, it provides you the risk level, and it also offers you what is the next step on your part. Do you give them simple advice? You congratulate them. There's no issues here. I see that you filled that up. Thank you so much. It looks like you have been abstaining from excessive use. I'm not so sure I would use the exact terminology. I would match my language to the patient or the client, or maybe you need to have a brief intervention, a conversation with that individual. Maybe have a high risk score. You want transparency as part of this process, and we'll talk about that in a bit. But this at least gives you what the scoring means and what you should do. And so here's the craft for youth. Here and and the scoring levels and how this correlates with the DSM-5 and kind of starts to give you an idea of how to have a conversation, how to follow up. This is the audit. The audit is the one that little pyramid was mostly associated with. So that audit tool is pretty important when you think about how the scores are. So it does look at different aspects of, say, of the frequency of use, whether the person has some control over the use, and that also correlates with the kind of diagnostic criteria for an alcohol use disorder, the harmful levels of alcohol use. So the different questions refer to different components. There are a bunch of different ways, there are a bunch of different tools, a bunch of different ways to be able to screen in the immediate moment someone's level of consumption. It's not the end all, the final word. It is simply a screening. It simply identifies a potential issue to explore. And that's what the substance use screen does and help in the screening component of SBIRT. The CRAFTS tool for, there's like 4 different versions. The CRAFT tool for youth, it's often used because it's been seen so effective in the way it works to identify issues. And all of this is only for you to see a potential issue to explore. Here's the thing I want to make a stress. I want to stress, and I'm going to come back to the slide in a minute. Most of us, whether we ever did screening before, or we're doing screening now, or someone else is doing it, and then we see the client and all that information is already in the folder. That screening is not unusual. It's usually, for most organizations, part of their intake protocols. Those questions are asked, and some other questions are asked. And I'm going to go with my experience. And so what I want you to think about is, when you have those questions in your intake process, is there a score? Is there interpretation? Many times, what those screening protocols refer to is you ask those questions, but you don't stop to do anything about anything that you have. You continue asking the other questions because you got to gather that information. And so, and oftentimes that's when somebody's first is eligible and is being admitted to your program. So with SBIRT, what we're saying with the substance use screening, it provides an opportunity for you to know the score, how it translates, and then whether or not you should have a conversation then, not a week later, because a lot of times that's what we do. Screening, how do we capitalize on that opportunity there when you have them engaged? Because we move on to other questions, and then it's like that provides you a lot of opportunities. And so that's what I want to talk about here. So I'm going to go back to the slide. No matter what the validated instrument is that your organization uses, most people, when it's not, I'm talking about outside of substance use treatment, healthcare, prevention, other community organizations, harm reduction, so what they tend to see is that most people are not harm reduction, but most people will fall under the 75% category. But you will be able to identify a good amount of folks who may have high risk, moderate or high risk consumption, and the opportunity to be able to have a conversation. So thinking about that, and again, the audit is like the most familiar tool in behavioral health. That's the one of the oldest, and is one of the ones that have been used most frequently. And so, but what is nice is, again, we don't always have the scoring and interpretation within our intake processes. And so it's so important to understand the risk level that the individual may be, and be able to at least score it, identify it, and maybe the next person that's going to meet with that person, that community member, can understand what intervention they would need to facilitate. Sometimes it's done by the same person, sometimes it's the team that facilitates all these components. And so But one of the things that you also want to consider is the confidentiality. Confidentiality with adults is such an important message when we think about facilitating a screening. Say someone is going to your agency and they're looking to get support and help around housing issues, and you are doing an intake, and part of the intake, you ask one of these questions, one of these tools, and it finds that they're at moderate risk, but they're there for housing. Well, you may want to facilitate, if you're there for housing and you don't know if they are, and you haven't facilitated the screening tool yet first, let me take a step back. You want to set the atmosphere. You want to be able to explain how confidentiality works with that person. One of the things that we want to do is when folks are coming to our organization, we want them to be in a safe environment, understand where their information is going to go. So people who are concerned about privacy are more likely to seek healthcare and speak about alcohol and other substances if they're aware that the comments are kept confidential. Something to keep in mind, something that we know from experience. If you're going to bring up the issue of any type of consumption, and yet they're not there for that reason, then you want to make sure that there's that confidentiality is clear for that individual. So explain how that works. Even ask them if they have any questions, or they can explain back to you how confidentiality works in your setting, and then go from there. The other thing is, if you're working with youth, OASIS has a particular way to work with youth in the school setting. What I will say about the school settings in New York is that the healthcare practitioner is the only one that I know as of yet that can actually facilitate SBIRT as a model with anybody without anybody's permission, because it's a health model. It's really about that person's health. And so a doctor, a nurse, the school nurse, they may be able to screen someone and then be able to have a conversation about it. And in a more formal way, to include those protocols, you'd have to go through a process including parental consent. The thing with talking with youth in any kind of structure is really about, if you're going to have a conversation with them, it's how you approach. It's how you approach them in that conversation. Confidentiality means that they are aware that no one else is going to get in the information, that it's not going to go back to the family, that it's not going to go back to any peers. And so because there are state laws that do provide rights for patient rights to adolescents. And so understanding what that is and bringing that information to a youth can be very helpful in terms of their being motivated to have a conversation with you about consumption or not. So you should explain the full confidentiality policy. And if the adolescent is willing, you can even explain confidentiality. If they feel more comfortable with the parents, in the room, that's fine. What happens a lot in hospital settings or emergency rooms is many times, depending on the situation, doctors or a physician assistant will have a conversation with an adolescent and ask the parent or the guardian not to be there. And so, but the sense of safety, safety with information, the safety for the person to be able to have a dialogue, that when they know that it's not getting to anyone, that's the biggest part of confidentiality. And so here I'm saying screening tools have to be facilitated, but they have to be facilitated. When you are facilitating them, you have to ask the questions verbatim. Can't deviate, can't paraphrase, has to ask the questions exactly as they are written. Let's just say your intake process does have a scoring and interpretation, and then you have this SBIRT model integrated in there. And so the concept here is, before someone's coming to your organization for some, some employable skills, you have a program in place, maybe you have a nutritional program, not just housing assistance, so you have any one of these. And then you want to facilitate universal screening with all your folks that you provide any kind of service to. How would you engage someone in that process? So in order to even ask the questions, you have to create an atmosphere that is culturally and trauma informed and affirming, and provide a sense of safety for the individual. So confidentiality is one part and one aspect that helps you do exactly that. And so how you create an atmosphere of trust is not just the physical space, but it's in your approach. So how do we engage folks? I can say easily, so my name is Diane. By the way, I go by the pronouns as she, her, and ella. How can I refer to you? I mean, I have your name here, but can you tell me your name? And then start a conversation, almost start to build a rapport rather from right there when I first meet the person. Kind of invite them to talk back, to talk with me. And so the space can be culturally appropriate. Your approach is trauma informed. You want to be affirming in your process, in your engagement. And so the whole idea is, can a person feel safe and comfortable enough that you might be able to ask or suggest that you want to ask some screening questions. And so part of what we can do here, and this is just a suggestion, is I'd like to ask you some questions that I ask of all my patients. These questions will help me to provide you with the best care possible. As with all medical information and responses, they are kept confidential. And we can stop at any time and start again whenever you're comfortable. Would that be all right with you? So the whole idea is I want to celebrate their autonomy. I want to respect that. I don't want to force anybody to answer questions that that's not even relevant to why they're even there in the first place. I want to be able to engage them. So in order to engage them, I want to initiate that rapport. So would it be okay if I ask you some questions that I tend to ask of all my clients? I said, they're here, they're just there. These questions will help me understand how to best give you the best care possible. And so I'm trying to make sure that the focus is on them and they understand and they hear it. And so I explain the confidentiality. I could also say we can stop at any time. We can stop at any time and we can start again whenever you're ready. Would that be okay? So that provides, that puts the onus and the ownership really on the individual for them to be able to decide whether or not they want to engage. They always have the option of not engaging in a conversation, but we want to make sure that they're included. They don't necessarily have that experience the same as everyone else, as the same type of experience in other places or when they seek out other social services. So that's important to know. So we want to create that safe space. Typically in the lengthier 12 hours SBIRT process, we go through this a lot more specifically in this 4-hour version. The idea, the concept here is to understand that creating that safe space is going to increase the likelihood that that person will be responsive when you do ask, if you have permission to ask substance use specific screening questions. So let's review. First of all, screening does not provide a diagnosis. Let's be very, very clear. It doesn't provide a diagnosis. Even when someone scores high, even if they do that, it only shows that high level of consumption risk. That is not a diagnostic process. So we don't say that you probably have a substance use disorder. I can't say that. I'm only screening. So I do not have any credibility for that. So we want to make sure we stay within that context. And that also benefits because it helps keep the person engaged. Screening does not provide immediate identification of level at risk. And that's what you're looking for. Because if there is a level at risk, then we want to understand how that conversation can go, if there needs to be a conversation. And there are 2 levels of screening, the pre-screener and the full screener. If someone scores on the pre-screener positive, depending on the pre-screeners, I did not go over those specifically, but it's the same concept as the full screens, then you want to use a full screen with the individual. A lot of times you can get through a lot more questions, and folks don't always have to ask the full questionnaire of the full screen. And you can just use the pre-screener for that. And it's just to be able to identify what folks you should do it with and which folks you don't have to. So the 4 types of intervention include the 2 levels of screening, and plus a brief intervention or extended brief intervention, which we'll discuss after the break. CJ, does that mean county jail? Typically, that means criminal justice. Confidentiality is not always possible in a criminal justice setting. Well, if you're doing a criminal justice setting and you're going to do SBIRT, and I have not heard of SBIRT being incorporated in a criminal justice setting specifically, but it can be included in some of the ancillary services that are part of the resources that, say, problem-solving courts or drug courts use. So a screening tool specialized for military or incarcerated individuals and other groups. Actually, you saw a variety of them. And so those are the types of substance use screenings that everyone has a choice of using. Matter of fact, there is a link at the end of the slides that has the SAMHSA list of validated instruments. What's interesting is who is using it. For the military, they use some of these screens. In the military, often they also use the mental health screenings as well. They're not incorporatable together. They're two individual types of screen. It depends on what the agency or the organization wants to use. And so if you have incarcerated individuals or criminal justice involved individuals who are in your program, say in your prevention programs, you will still use some of these substance use specific screening tools. Like if someone was court mandated to complete an SUD program, well, if they're mandated to complete an SUD program, that means they already have the paperwork as justification for them to be in your program. Typically, from my work over the years with the drug courts, what they've done is they have typically have that documentation in place. SASE is a proof of, yeah, SASE. Google the SASE because that's another screening tool. So clients can also manipulate their response to get admitted or rejected. So what I'm going to reread that as clients are also trying to meet their needs for whatever reasons they have at the moment. I'm going to stay away from certain words, and I'm going to do that intentionally because if whether or not they do, if they don't, then guess what? If you do an SBIRT and you ask permission to ask, these questions, and their questions are not reflective of how you would expect them, you still work with them where they're at. We're talking about a preventive and person-centered approach. And so we're going to work with people where they're at. But what's interesting here is that it kind of depends on the dynamics that they come with, what's going on in their circumstances. So I would suggest just to keep an open mind with that. Because if you're going to meet with the person more than one time, you have an opportunity to revisit that issue later on. So I want you to see this. And this is a very old grid, but it just shows how it can happen. Like a screening everything does not have to be done by one person. The screening can be done at the front desk. That could be, many times we go to our doctor's office, and in our doctor's office, we update the information on an annual basis. And so even within there, many times what I have seen is they'll ask either that one question of like the drinking guidelines, for the last 12 months, or they ask a couple of, they're asked about 3 questions, like a pre-screener of some kind, and they'll have that inside that paperwork that I have to submit on an annual basis for me to access my medical care. And so what I've seen is that that's an opportunity, or when they're going into your community-based organization or your whatever location that you're working at, in the front desk, that you can easily give someone a screening, a form, and they can self-report themselves, or you can include the questions in those forms. So what happens is that person will respond, they will give the paperwork back when they go to see they go to see Adam, they go to see Joanne, they go to see Tiffany, at that point, you already have some of that information in your hand, and you already have a score. You can score or you can score the actual tally up, the responses, score it and interpret it. And that will help you understand whether or not you should incorporate a brief intervention conversation or a brief intervention dialogue within the meeting that you're going to have with that person in a few minutes. And so if it's a positive screen, you don't have to do any further activity, just whatever issues they came there for. Or if it's a positive screen, depending on the tool you're using, you have a score interpretation, then you want to include that in the conversation you're going to have. So what happens is that many times it's a team effort. So sometimes they'll have someone or a certain place in the walkthrough of the services in an organization as to where the screening can take place. Then another person may be the one that actually scores and interprets and provides a brief intervention when needed or not. And then sometimes what they'll do is if a referral is indicated for further assessment, then that gets done by another person. And I'll talk to you more about that later, but it doesn't have to be all on one person. So most practices use this team approach. Now, I just gave you a whole lot, and I have a whole lot more. And so I'm going to try to do my best to provide you as much information as possible. So let's just say we have the screening. So we think about those considerations, the language. We understand preferred language is appropriate because preferred language also has to do not the same words, but the comprehension is really important. And that's that's a federal mandate on us. So substitute screening, which it depends on the instruments that your organization is using. If you're not facilitating the screening, that's fine. But find out what screening is being facilitated, where it's being facilitated, and learn to see if there is a score or an interpretation. And that way you can utilize the SBIRT process within your practice when you interact with your folks. Okay, so do that. Find out what you're using and how it's supposed to be, how it's being facilitated. And then we're going to talk about engaging someone in a conversation when we come back. A screening tool only identifies a potential issue to explore, and that's all that it does. And so I always want to reiterate that our language should mimic or translate into what we're doing at every different point of the SBIRT process. Any comments, any questions left? Very good. So it might be a little early for some folks, but this is pretty much the middle of the actual training. Would you guys mind if we take 30 minutes right now and come back? And my time would be 12:30 or 30 minutes from whatever time is on your watch. Are you folks okay with that? Yeah. Awesome. Let's come back in 30 minutes. Thank you, everyone. Great questions too and comments. All right, real quick, before we start, I'm going to ask any outstanding thoughts, comments, questions. I know I'm going through this pretty fast because it's a 4-hour version. This 4-hour version is supposed to be for actually designed specifically for licensed practitioners who want to bill, and they're only required to take a 4-hour version. And I wanted to make sure, I always do the 12-hour, but I want to make sure I give those folks an opportunity as well. But any questions that stand out, any comments? Very good. All right, so again, I'm going to breeze through some highlights of certain points. I'm not going to get into it too deeply. I can do this in a 12-hour if you folks want. Okay, all right. Module 4, brief intervention and essential motivational interviewing skills. I'm only going to touch on some points. When I work with organizations, I request that part of the plan is that they get updated with a motivational interviewing training. We have skilled providers in my organization. We are actually funded by the Department of Health and Mental Hygiene to do nothing but motivational interviewing and one of our other programs. But it's really important that we'll get updated to understand what the MI principles are. This uses like the most more recent information. So brief intervention. We went through the first component of the SBIRT model: screening, brief intervention, referral, treatment. We went through screening, and we understand that if you're walking with a patient or a client through the services at your program, or how they will walk in and the different tasks that they have to go through in order to access services, then we see opportunities for where screening can take place. I think the most encouraging and the easiest way to integrate screening is to have a person self-report. We're asked to do that all the time in other social services and medical care. And so that would be an easier way to do it, let folks report out on their own. But that's not the only way. I'm just saying that that is an opportunity. So, because what we want to do is integrate SBIRT, not just in your individual practice, but you can incorporate it as part of the organization to see the feasibility of it, different components happening at different times. So this fourth module starts to dive into the brief intervention component. Now, based on the screening score of the tool, if a person screens at moderate or high risk of consumption, of use, then that would indicate the need to have a brief intervention as far as the SBIRT model is concerned. So what it uses is certain concepts. And so we do look to see, we want to incorporate that, the idea that folks are motivated by different things in their life to move in a direction of change. If it's feasible, if it's beneficial, they are more likely to be motivated to go towards that change. And so, but it works differently for everybody at different times. And so we know that ambivalence is a huge part of what many people feel at different times. So it's a state of being in conflict with oneself when a person wants both, but doesn't want to do something about some particular behavior. We can also think about our own personal environment where maybe we wanted to incorporate a new healthy habit or stop doing something we didn't want to do. But the first thing that comes up always is smoking cessation. For me. And so, things like that. And so sometimes people want to, but they're not necessarily ready at the moment. And they just kind of feel, on the fence about things. And so the stages of change are very appropriate because people are in different places at different times for different reasons. And so pre-contemplation is really when somebody's not considering a change, and so, and it could be that somebody comes into your organization for a particular service, and yet you have permission to facilitate some substance use screening questions, and they may not be necessarily thinking about a potential behavior or consumption has anything to do with why they're there. So what you have the opportunity to do when someone is in a pre-contemplative stage, not thinking about a particular behavior, is you have the opportunity to raise their awareness and hopefully move them towards contemplation, which is, seeing the possibility of change and seeing the benefits and being able to resolve the ambivalence. And so you may help them to do that and help to choose change. And from there, there's the other price as preparation, when someone is thinking that there is a change they probably should do, and you're going to help them identify the change strategies. Another place and stages of change is, when they identify what strategies and set an actual date as to when they're going to implement the new strategy. And and help them also identify potential challenges or barriers that may come up and how to work around them. And so maintenance has to be, refers to a person keeping that changed behavior. And most people are creatures of habit. We're more conditioned than we're not, and more conditioned than we are aware of. And so it's not unusual that with a new habit, we might fall away from the new habit, go into the old habit. And we've been doing that for a long, long period of time. And so with substance use, we call that a relapse or recurrence, but it can be in all other behaviors as well. It's just maybe reducing, consumption, maybe not reducing the amount of cigarettes someone's smoking, maybe not taking a prescription medication to mitigate certain health issues, so a person can have a recurrence, and you could go back and have a conversation with them and kind of help them bring back, raise their awareness again, and maybe incite that motivation in an individual. These are core principles that are foundational to the motivational interviewing skills. And this is very much centered, or the core, I would say, of the brief intervention. So motivational interviewing is a person-centered. This is a mouthful. Matter of fact, it's a person-centered, evidence-based, goal-oriented method of enhancing intrinsic motivation to change by exploring and resolving ambivalence with an individual. And so the idea is that there are benefits too of motivation. So motivation is the key factor as to why somebody will move in a certain direction, do something and not do it. And it could be pretty dynamic. We can think about times where we worked with folks who provide services, and they were looking to access other resources to help their wellness process. And then something comes up the next time you see them, and they're no longer willing to do that. Something else came up. So I'm thinking of my days when I was doing prevention, and I'm thinking like when an individual wanted to seek support for abstinence, but then what happens is that notice, of dispossessed came up, and guess what? Nothing gets done because having a roof over your head took the priority. So motivation can change and fluctuate, and different things can pull and push people in different ways at different times, but it can be influenced. And so what we want to do as provider using the MI approach is elicit and enhance motivation in that individual. So one of the things we do talk about, and we unpack this very specifically in our 12-hour course, it's the way a person is with a person is really important. So that MI spirit is how you are present with that individual. Are we collaborating with them? These are different aspects of being present with somebody. Collaborating with them, getting into that partnership with an individual, not as you as a person of authority, and them kind of feeling like, they need to be very submissive because they need your services. And that's just an example. That's not an actual, an actual thing, unless those are the dynamics involved. It's really about ensuring that we can speak to the other person as another person, and not as necessarily as somebody we have authority over. And so when you collaborate with someone like that, and even heal and balance out those dynamics, you're more likely to be able to work with them in their process. Compassion is one of the key factors, one of the key aspects or attributes that we bring. One of you folks are doing this work because you like helping people. That empathetic part that you bring with you to help understand and help meet people where they're at is a huge, important component of successful outcomes. We also want to be accepting of the individual. When we do want to meet somebody where it means it's more than, it's literally exactly that. And so some folks may be motivated to want to do something, but don't feel they have the capacity to. We want to be able to hear what they say and recognize that, and what they're willing to do, what they don't want to do, and understand that's where they're at, and we can stand right there. Still part of being present with them. And evocation is really about a strength-based approach where you can work within the asset that a person brings within their capacity. And so the spirit of motivational interview has all these different perspectives that kind of comes together. And there are 4 processes or really like, I believe that the 4th edition of the MI actually speaks to it as 4 tasks. It's about engaging individuals, focusing the conversation on what is the change, evoking the strengths, and planning. And so the evoking is really the client's own motivation to change. We want to incite their motivation, and part of how we do that is raising their awareness about and being able to associate a particular risky behavior with the goals that they want to achieve. And so the developing of the commitment to change, forming specific planning of action. The other thing is, the thing with acceptance is it does celebrate their autonomy. It is their choice. This is not something that we do where we make people do. We don't have to be responsible for that. It's up to them if they want to be. We can use certain communication skills strategically to help acknowledge and recognize where they're at. But it doesn't mean that the conversation is over. What we want to do is be able to share information with the individual and get their ideas about that, And ambivalence is more than normal for any given person. If you've ever had to try to stop smoking cigarettes, or if you ever had to stop eating that chocolate cake every day, if you've ever had to change any kind of behavior that you deemed unhealthy, and what you had to go through to get to a better place with that, then you understand that ambivalence, and sometimes we can go back and forth with that. So avoid the writing reflex or the fixing reflex. I put it like that because the last edition of MI says, avoid the fixing reflex. What do you folks identify as that? It's just, you folks tell me. What's the fixing reflex? Or the writing reflex? Either one. They both mean the same thing. What do you think? Julianne, thank you.
It's like the desire to fix somebody's problems.
Okay, that tendency to resolve, I guess. Yeah, okay. Debbie, thanks.
It should be the client's, the patient's words. It should be in their own thing. So you shouldn't try to make it your own thing.
Yeah. So thank you. So we're thinking here is, if we're using a person-centered approach, which I mentioned very early on, and when we're in our efforts, we know we know intellectually, we know we're supposed to be person-centered. And there are times, let me just give an example. So there's a time that somebody comes up to you and they had already had spoken to you and they were engaged to the point that you had both agreed that they were going to get resources from you. They were going to start following through on a different community resource to help support them in some area with their family. Then they come in one day to get that resource, and what happens? The whole conversation changes, because at that point they're no longer feeling like they are open to going, or they're feeling like they think it's too stressful, it's too much, and they just got too much on their plate and they can't do anything right now. And sometimes we hear our clients and our patients or people who provide services to actually share some real hardships and some real stressors, especially if they're going through a hard time with family members who are sick, especially when they're having a hard time maybe getting employment. There's a lot of stressors in our days, and most of us are familiar with that. And sometimes in our heart of hearts, what we want to do is say, listen, but I know you wanted to go, and says, don't worry, you won't be alone. I'll be here with you. So don't feel bad. I don't feel like you can do this alone. So tell me about that approach that I just used with that person who came in for resources and then changed and said they can no longer feel like they can come through, that they are too stressed to do anything right now. What do you think about that? It sounded like she was going through a hard time, and I acknowledged that. What do you think, Debbie?
Made it more of a partnership. You validated them and made it a partnership.
Okay, Jolene, I'm sorry.
That's okay. You have to meet the person where they're at, and you have to be able to work with the client and just, build that healthy relationship that maybe they may not be ready right now, but they might be eventually, and they might come to you.
Okay, thank you. Carolyn?
Unmute myself. It's, you want to be helpful, but that's sort of like now taking control, or making it your responsibility to help them through this. Yes, we are to walk with them, but there seems that there should be some more conversation. Maybe there's some things that the client needs to talk about, the stresses, the things that maybe are making him or her ambivalent about moving forward. And so it's still about them and, empowering them, but being beside them as they kind of work out what it is that's going on, that's keeping them from moving forward. Because being with them, or saying, I'll be with you every step of the way, that's what support systems do. But they allow the people to, or empower that person to kind of come to terms with, their own strengths. It's about building, resiliency.
Okay. Thank you. I'm going to take all three comments and I'm going to bring it up together. Terrence said it, person-centered. So person-centered, in our heart of hearts, we hear the tone, we hear the stress, we hear the hardship on the person's part. Person-centered approach is we do walk with them, we do partner with them, but that's how we meet them where they're at. If at that moment they are not ready to do anything, it's okay, I hear that you're not ready to do anything. How can I help you right now? So what's most important is not my agenda of what I think should happen or what we agreed upon. If they took a different direction and something else is taking priority, I meet them where they're at. I acknowledge that. It doesn't mean that the conversation is over, but if that's where they're at, I want to recognize that. I want them to hear me say, I hear what you say is that you can't do that right now. So what is it that you are looking to do, and how can I help you? So I can do that approach. It doesn't necessarily mean that a conversation is over. Where we are always looking to resolve, and the fixing thing, I wanted to speak on what Julian said too. We are always looking to resolve. And so we have our eye on something. We want to make sure we have to have our eye on what the client has. Where is the client looking? Right now, if your client is getting a dispossessed, guess what? Going to that resources or that resource for say for childcare is not the priority. It'll be how she gets help for that dispossessed if she doesn't have a roof over her head. So you got to take care of the immediate issues. But but I'm not trying to resolve a case. I just simply want to acknowledge that's where she's at. So in a conversation, someone is looking for, the plan was to get, to provide referrals to a resource, and they come in and say, so, okay, so would you like to talk to me about that? I hear that you're saying that you don't want to, okay, and I hear that. Tell me how you feel about that. And just have to keep going the conversation. It doesn't end all, but I want to be able to let her know or let him know that I heard what they said. If I can acknowledge it and they can hear me acknowledge it, then I'm still present with them. I'm still right there with them. And that's just something we can do in the moment. And so fixing it means restraining ourselves from our empathetic side from wanting to take over and resolve something for someone if they're not ready at the moment, or even if they change their mind. There's still more conversation to be had. Doesn't mean that they will get to that place in that conversation. You might need to sit with them again, and that's fine. But you want to be able to literally meet them where they're at. And so that's what fixing it is for us. They can move back into that place of ambivalence, and then they may not gravitate again towards that initial healthier goal that they had first agreed upon. So we're not responsible for changing their behavior. We want to support them in thinking about their own reasons why they might need to change their behavior. And so we have some core communication skills. Or it's open-ended questions, affirmations, reflective listening, and summaries. These are used, and when you do an MI training, you use these, you unpack these very specifically, and then you could practice using them and reminding yourself of the importance of them. And so we're not going to go too extensive into this, but open-ended questions have its benefits. It's a great way to invite someone into a conversation. Affirmations is a great way to let someone know to hear what someone says and to acknowledge the strengths that the individual is reflecting. And reflective listening lets people know that we're there, we're listening to them. And summaries is kind of like a recap of the whole thing. So this can be a huge advantage. You know, when we use these core communication skills very strategically, the idea is that with opening the questions, you invite them in a conversation, you keep and you can keep the conversation going just simply with reflective listening, with affirmations along the way. You're really not supposed to be the one talking most of the time. The person who's supposed to be talking most of the time is them. And so the idea here with motivational interviewing is to help incite change talk. And so how would we help create that or help motivate that? For someone to feel like they have a reason or think they should make a change, and they come into your office, they need to hear something that kind of speaks to who they are, their values, something that's important to them. And so if it resonates with them, you're more likely to actually incite change talk. There's also the possibility that in the moment that your conversation is going and there's nothing but reasons to stay with the same behavior. We don't overemphasize that. We don't stay in that conversation too long. We change the direction and go into something else. We don't want to reiterate sustained talk with folks. Mostly what we're looking for is change talk. When sustained talk comes through, there's certain ways you can use your strategies to help address that. So you want to elicit change talk, you want to ask evocative questions. You know, what kind of questions can be evocative is really about thinking about things like, where does somebody see themselves? And, you know, they just shared about a particular issue they're having. You're asking them, so where do you see yourself in the next 6 to 12 months? Change rulers, I will go over that in a minute. So you want to query extremes, either looking forward or looking backwards. You want to be able to, you know, very tailored and very specific to the individual. You want to be able to use some of the content of some of the information they shared and see where they see themselves. You want to explore goals and values. And so much more of this can be had if we did this in a lengthier context of a training. So I want to share with you about the importance ruler. We call it the change ruler, and many times people used to call it the readiness ruler. We haven't been using readiness for a very long time. And so importance rule is it's what's pertinent here. So the developers of the motivational interviewing strategy in the third edition back in 2013, and a lot of folks did not catch up to this, has suggested that sometimes when you do give information to someone and the kind of it increases that awareness on their part, where they get that information and they kind of see how it relates to them, that you might be able to ask a question, for instance, on a scale of 1 to 10, how important is it for you to make a change in your drinking or substance use? And so important would be a way to kind of assess the individual's level of motivation at that time, considering how they're starting to see how their level of consumption is affecting their life or what it is that they want to achieve. And so if a client says 6, you would ask, why not a lower number, like a 4? Who can explain this to me? Does anybody understand about this? Anyone know how to use the scale that would like to explain? Okay. Let's see if I can ask someone. Somebody volunteer to let me ask them a question? Debbie, okay. Thanks, Debbie. All right. So Debbie, I see we were talking about smoking, and you didn't realize how much that may have an impact with some of the heart issues that you were sharing with me. So let me ask you, on a scale of 1 to 10, how important might it be to maybe reduce the smoking? With 1 map being important, 10 being important, how important might it be to you to actually reduce the smoking?
4.
Actually, that's a good number from the scale of 1 to 10. But you could have responded 2 or 1. Why didn't you?
Other things more important.
Okay.
I'll put it in the middle.
So you put it in the middle. Okay, we can work with that. Thank you. So thanks for doing that with me. Now, everybody else, when I asked Debbie that question, so she responded, how do you see her response? And I don't mean for you to measure it. When she responded and I asked her why, what was she actually doing? Joanne.
She actually had to think about it for a second and give an answer. So it actually, I mean, it's a forced way of getting her to look at the issue, even if it at first is superficial and on the surface, but then your second question adds another layer to it. It's like, oh, you picked this number, and now let me ask you why that number, why not lower? And I think by going lower as opposed to a higher, it gives the person the opportunity to really, I think, to kind of take a harder look at maybe the severity of it. Because I think if you say, why didn't you go higher? They're like, oh, because I'm not that bad. Right. But if you pick let's say, hey, why didn't you say a 2? It kind of they have to think about, oh, because it's more significant than a 2. So maybe it is even a little bit more serious. So it just gives them more food for thought, I think.
Okay, thanks, Joanne. Julianne?
I was thinking it makes the person kind of focus on their strengths as well, because if you're asking, why is your confidence in this not lower, then they have to think about what's working for them in order to answer that question.
Okay. So what I asked was the importance. I just want to ask Debbie. Debbie, let me ask you a question. Did you feel like I forced you to respond?
No, well, not to respond, but I put it in terms of pizza, actually. So I was just thinking, like, comparing myself to other people. So it gave me a chance, like, to think about other things. So it was, I had to step back from the situation.
So when you're having a conversation with somebody, so this is supposed to be, there naturally would be some comfortability, because if someone is being forthcoming, you get to the point where you have shared information and you can ask them a question like this, And you, first of all, one of the first things I did was I acknowledged that number that was given. I want to recognize it as a, not with any judgment, but say, thanks, that's a good number. Thanks for that. But you could have answered something lower. How come you didn't? So that gave her an opportunity, and I'm going to use my words with this, gave her an opportunity to defend that for. She associated with her particular reason. So I evoked some change talk from Debbie. I did not tell her what to do. I did not tell her how she should do it. I only asked her why not. How come she didn't go low? Because she could have. And she gave me a reason. So when we can do that, particularly after someone is starting to say, well, you know what, I didn't realize that smoking is what has anything to do with my heart. I thought it was just my lungs. And that's just an example, because we could use substances in a lot of different ways. Somebody may come in here and say they may have, maybe they have high blood pressure. They come in for high blood pressure, they're doing housing, and your screening score shows a moderate risk. What do you say? What the conversation is, after you've already evolved in a conversation and much information has been shared, you could always ask and says, well, let me ask you, on a scale of 1 to 10, knowing that the alcohol can actually exacerbate, the depression, well, how important do you think on a scale of 1 to 10 might it be for you to do something about that? So somebody will say, well, I didn't know that before. So I think there's something that I need to look at there. You want to recognize that. Well, you know what? I don't put those words in that person's mouth. They said it themselves. So that's evoking change talk. That's just a brief example where that person themselves acknowledges, you know what? They looked at something. That's inciting motivation. That is coming from them. I'm not putting words in their mouth. And so that was just a quick example, but really in the context of a real conversation, it happens very naturally, where folks are already sharing with you because they're comfortable, and you are able to see, okay, so you have these, say the person has these goals, but their high blood pressure kind of gets in the way, but they're drinking at this level. So you are able to kind of connect it to their values, connect it to a goal they want to achieve. And so it's a health approach. It's not targeting a substance use problem from their perspective. They're more likely to engage you and keep you in a conversation. It's kind of, some people call it a little trick. It's not, it's a communication strategy. So you have all these skills. You have open-ended questions, affirmations, reflective listening, summaries. You're able to speak with people with the pros and cons. You all have those skills. But in MI, what we are asking you to do is to do it with intention. Use it strategically with intention for particular results, depending on what you're hearing. You have that opportunity available. So that way we're not directive in our conversations. We're more likely to incite motivation. They think of their own reasons why they have to, they probably need to make a change, and then you can help support them with that. So let me go back to you. Thank you, Debbie. And thank you everyone for the comments. The developers themselves, they had eliminated the word readiness because it's hard to tell somebody, so how ready are you to make a change? So that means that's our agenda. If we say readiness, we say, ask how ready somebody is, and we're not doing our agenda. We're trying to meet them where they're at. So we can ask questions like, how important might it be, if anything, to do something about that? And then in the conversation, maybe a second time, you may ask, you may or may not, but how confident are you that you could do this? And that's as the conversation goes. And so, and there is an array of MI videos on YouTube, or when you just Google them, and you can see how this can work out. And so you get an idea of how to do this. I really encourage you to do an MI training. And so it's a way to assess in the immediate moment their level of motivation, and kind of just build on that change talk that you're looking to hear. And so sometimes there's a sustained talk. Like if I'm talking to you, look, I don't have a drinking problem. You're talking to me and I'm saying, no, my dad was an alcoholic. I'm not anything like him. Oh, I just like the taste, Sometimes when you hear certain verbiage, certain comments, that keeps that same kind of rationale, or that type of talk, you don't want to engage or, reiterate that. And so like change talk is more like something like, I really need to quit smoking because of the bad example I'm setting for my kids. Or somebody says, no, but I love smoking. It's so much of a part of my life. Well, you don't want to support that. You would, if you hear change talk, you want to keep that conversation going. If you start to hear sustained talk and the person doesn't move away from that, no matter what strategy you use, then you want to be able to end the conversation, because then that gets more concretized with the person. And here are some examples in here that you'll get in the handouts. The idea is that we're going to provide feedback, and we're going to elicit in small increments of information. So we can provide information like, I can tell that person who maybe has high blood pressure, maybe has depression, and I tell them, I says, a lot of people do tend to take a drink or two to relax. And then what they don't always realize is when that feels good and they want to stay feeling better, they may have a third and fourth drink, and by that time, what it does, it actually stresses the body systems more. What do you think about that? Something small, something relatable, something that fits perfectly within the conversation. So you want to ask that person's perception, provide the feedback with their permission. Also, because somebody can say something to me and I can say, well, I have some information about that. Do you mind if I share with you? And what I'm going to share has to do with the risky behavior, but it's going to be tailored to what their situation is. And then ask for their feedback. Okay. So the brief intervention is time limited. Let me just say that when it comes to SBIRT, it's in a matter of minutes. It doesn't have to take anywhere between 10, 15, 20 minutes, if that. In the emergency rooms, they do them within 10, 12 minutes. We can do them in 10, 12, 15 minutes, depending on what the situation is and how good you get at this. The idea is practice those ORs with colleagues, with each other, before you practice it with the folks that you're providing services to. So you could get comfortable using them intentionally in the forefront, as opposed to in hindsight. So the goals of the BI are fluid depending on a whole bunch of different factors. It's really about meeting the person where they're at so they have the best idea in the room. And those MI skills and the MI spirit are fundamental to doing that brief intervention. We want to elicit change talk and end with change talk. So module 5, when we think about the skills that go into a brief intervention, let's remember, so based, justified, as a matter of fact, by the screening score. We don't have brief intervention dialogues in SBIRT just because we really feel like they weren't responsive on a screening score. We work with a tool that documents the level of the risky level of consumption. You score it, you interpret it, and then that is your reason for having an intervention. And this is especially important for folks who are doing this to build, because if you don't have the justification, you will not be reimbursed. And so the brief negotiated interview is not far different from what an MI is. And so the brief negotiated interview is one of 3 different ways that a brief intervention can be facilitated. OASIS takes this stance, and I've been training it with this approach for a long time. The BNI, which is short for brief negotiated interview, it was already a standalone evidence-based process. Just like the validated instruments were already validated before they put it together in an SBIRT model. But they use this component to explore the person's behavior, the health, in a respectful, non-judgmental way within a finite time period. And that's especially important for many of us who have to work within a time construct. And managed care did a lot to the field where everything had to be done in a shorter period of time, or everything had to be done yesterday. And it still has implications for how much time we can spend with any given individual when we're having a counseling or interaction, a session. And so this is such a helpful approach that you can help to identify and intervene with an individual risky behavior and within a few minutes time. And so the goals of the brief intervention are to educate the individual, that's on your part, increase their awareness by providing that information, help incite motivation for them to actually look at their behavior, perhaps do something about them, and assist them in that process. So it's pretty fluid. So it's based on the person's and that substance use screening score, person's readiness, or I'm going to change that word to willingness to change, and their specific needs. So it's such a tailored process. So you provide feedback, offer information, you elicit information, you elicit the person's views, understand what their world looks like, explore different options to support them. So you begin where they are. And so the first step is to identify where the person is coming from. What the opportunity presents is how to be able to correlate and associate that risky behavior with them meeting their needs. oftentimes someone comes into your organization for a particular service, and there's an opportunity, if they're at moderate or high risk, to actually associate that risky behavior with the reasons, with the goals they want to achieve, that they want your organization to help them with. So some things that can be helpful is having some basic information about substances can impact the body. A lot of people don't think about somebody with high blood pressure, if they have a couple of drinks to relax, which is a cultural thing in the Western Hemisphere. Many people come home from work, have a drink or two, and they relax. And if they do that several times a week, they can be conditioned to that habit for a long time. But if the person starts to have high blood pressure, that habit is not necessarily, healthy for them. But if they don't have that information and they show up in a screening score as a moderate risk because of that, you can make an association or a correlation between that amount of consumption with the health issue. So you're using a public health approach to address their health needs. So it's nothing about, somebody has substance use, problematic substances, or it's part of their world. We might see them as something negative, they need help. That's not the approach at all with SBIRT. It's just a matter of like, okay, so this is maybe associated with your health, you can use that approach. So how would the identified substance use affect a person's ability to benefit from the service they're seeking, or what their goal or eventual goals are? Because that comes out in conversation too. So you have opportunities to link them both. So these are some of the tools that we get to use. The brief negotiated interview is it's pretty old. It doesn't have the updated recovery-oriented language, but this is, but the BNI algorithm is the type, kind of guides the conversation or how a conversation would go. And we can always kind of look at it as a particular guide as we get comfortable facilitating a brief intervention using MI. And then this is a quick cheat sheet, and let me put it here for everybody. And so from OASIS, and this actually correlates some of the data that we have in terms of the population that tends to come up positive for at-risk use. And it has the recommendations for, drinking guidelines. And this is just specific to alcohol only, not for the other substances. But it does have, it's a quick pocket guide that you can download, keep on your desktop, print it out. It's kind of like a quick cheat sheet. And I always used to use those when I was doing direct services, until I got used to knowing by heart how the recommendations were, what the recommendations were, and I could do it on my own. But that's there for your use. So these are the types of tools that you would use for a conversation, a brief intervention conversation. And so let me just kind of piggyback on something I said earlier. So making it culturally appropriate and inclusive information sharing. And so inclusive information for non-binary people. And this is the specific wording that the OASIS folks wanted to use. So we have a center of excellence for LGBTQ plus folks. It's the behavioral health equity. And they are out on the West Coast, and they are a formidable resource to access. And you have a link down there. And so, or you could just Google that Center of Excellence on LGBTQ health and behavioral health equity. And so they have made some certain recommendations, especially when facilitating SBIRT, because of the very restrictive way that these recommendations are made, and not necessarily the most conducive ways to present them with everyone. And so transgender, gender diverse individuals in this community, what we want to do in order to facilitate a brief intervention, which we've been talking about all this time, is supposed to be tailored very specifically to the individual, so how do we do that when the risky consumption regards alcohol? So for alcohol, we have those recommendations, those drinking guidelines recommendations. And so when facilitating a brief intervention with a transgender, gender diverse individual, you want to provide the recommended drinking guidelines with transparency. It says, honestly, transparency pretty much covers that. Transparency and clarity, that really should be the second word. And here's the thing. So we want to acknowledge, listen, there are some recommended guidelines that we all tend to use, that we are given in our work. I said, but they've been developed with a binary perspective. And so I want to tell that to the person that I'm speaking to and let them know that, listen, this is what's recommended to use this perspective. I'm going to need your help with this. So it's offered to you to assist utilizing the appropriate guidelines as they decide what best suits them. So I have an example here. Tracy, would you mind reading the dialogue that is italicized? That is on a slant font for me. Would you be okay with that? Can you do that? Okay, I'm not sure she can unmute. Dan, would you mind reading this for me? Dan, Olet? I'm not sure. Is that okay? Let me bring this up.
Sure. So information and feedback, Latina trans woman. Well, I have some information about alcohol. Would you mind if I share it with you?
Sure, why not?
Bullet point 1, experts recommend drinking guidelines for people. Although these guidelines are based on a binary perspective, and if you are all right with it, you can let me know which one may best apply to you. Is that okay?
Sure.
Bullet point 2, the current recommended drinking guidelines suggest limiting intakes to 2 drinks or less in a day for men, not to exceed more than 14 in a week, and 1 drink or less in a day for women, not to exceed more than 7 in a week. Bullet point 3, which of these do you think might apply best to you?
Thank you. Thanks so much, Dan. And thanks for, I didn't tell anybody I was going to volunteer them to do anything, but I appreciate you working with me.
Quite all right.
So great reading. So let me ask everyone else. So just keeping this slide up, I just want you to consider if we have a binary perspective of some of our tools, okay? Because we're challenged as behavioral health professional, we're challenged all the time with different products and different tools and different points of information that are not necessarily translated in a recovery-oriented way and not necessarily as inclusive and affirming. So what we can do as providers is we translate that. And so the way it's put here, the way the dialogue is provided, this was suggested by the Center of Excellence for LGBTQ health, behavioral health equity. And they're the ones who suggested that this can be an approach that you can use to incorporate the guidelines, seeing how they're not available from an inclusive perspective, but you can help be transparent. Imagine what that can do to that rapport you're building with that individual, and and accelerating their autonomy too. When we ask their permission to do that, and then we ask, which of these you think might best apply to you? So that way, that person, they can respond how they see what gender they can identify with the most for the conversation purposes, and you can work with that. Okay, so that's the idea, is can you tell me which one we can work with? Which one best applies? And then you work with that, because that way you are being inclusive, you're recognizing the unfortunate binary perspective, which exists all over the place today. And we want to but this way you have the opportunity to be inclusive and affirming with that individual. And so if there's any questions about differences and the differences in recommendations, you have a smaller note that I included in there that speaks very specifically to the science regarding how these, what got involved in terms of generating or developing these guidelines. So we want to be culturally and appropriate, culturally and linguistically appropriate, trauma-informed, and inclusive when we are doing SBIRT. We're not compromising any of the components, but we are definitely trying to use a culture and an inclusive approach. And so for gender inclusive, that's just a sample, but you can see how the conversation can go. I included a Spanish version, a translated version of it. The 3 most spoken language in America today is English, Spanish, and Portuguese. So know your communities, whether they're Guyanese and you want to use Punjabi, or they are from South Africa, you want to use Swahili. Just understand who your community is, so you are going forward, you can be more culturally appropriate as well. And so an adolescent dialogue is a little different, because persons over 21, we don't ever ask them, You know, we say, so what can you do to reduce your drinking? What we do is something different. We can say, I could recommend, you know, you could, a matter of fact, let me get someone else to read that. Can someone else read this? Can I get another volunteers before I volunteer anybody?
I can read it.
Please do. Thank you. From information to the end of the blue wording.
Okay. Information and feedback. Well, I have some information about alcohol. Would you mind if I share it with you?
Yeah, sure.
Okay. So recapping what you stated here, and that you are drinking on some occasions where you have not remembered the night before. Your drinking is a concern when you consider how alcohol affects the brain. We know that brain development does well into your 20s, and alcohol can result in blackouts or poor decision-making, where sometimes people do things they may regret. I recommend that you don't drink until you have legal drinking age of 21, so maybe you can think about that. What do you think?
Thank you so much for reading that. So, and who was that reading? I didn't catch the name.
Faith Jackson.
Hi, Faith. Oh, hi, Faith. There you go. So think about it like this. Every single dialogue has an approach that is more inviting than directed. And that includes also youth. Youth are very used to adults talking at them, not with them. And we really need to be mindful of that, because if we're going to capture or any kind of information about any kind of substance use, if we want to have a conversation where they can feel comfortable, safe enough, and give us a chance to trust us, then we want to be able to speak to them as another person, as another adult, and not as a mom, a provider, an adult that knows better. None of that. We want to be collaborative. MI is really about that partnership, no matter who that person is. It's always about that. And so you want that tone to kind of resonate as, you know, you're having a conversation. So what do you think? What do you think about what I just shared with you? You're more likely than not to have continued conversation, have responsiveness from the individual. Terrence, so is this different from doing aspects with cisgender language? No, it really should. I'm going to go back into the slides and change it to cisgender because it's appropriate. It's inclusive. So thank you for that. That's what I'm going to do. So I will change that and give that into your slides, the slides set that you're going to give. The important thing here, and there's a lot of content here, but the important thing is to stay consistent with the concept, how it translates in our language and the terms we use, and in our approaches. There's different ways we can approach people where they don't feel targeted, they don't feel that they are told what to do, but they can actually they can provide feedback on what their thoughts are comfortably. That's huge. And a lot of times it doesn't happen if it's not us. If it's alcohol specific, those are the recommendations that you're encouraged to use. They're the ones that come out in the dietary plan every 5 years. It's the one the New York State Oasis kind of stands by. But the reality is, it's not just alcohol. A lot of times folks are misusing different substances, not necessarily with an intention to get high, but they're maybe misusing it and maybe getting in the way of the different things that they're trying to achieve in their life. And so whatever that is, you have the ability to be able to engage them in a conversation and talk to them about it. So you can build a rapport with someone. You know what else you can do? Also, we have the pros and cons. You can always ask someone. So, you know, when you do have to go, when you do have to like study and I know college is really stressful, as you shared it, and you have to take a couple of those pills to stay up and crash and study all night. What do you like about that? You know, and get their take on with the benefits of it. And then you said, okay, so and reflect it back. It said, so it helps you to get through all your work, and you're able to provide the assignments on time. So I'm curious. So what are the downsides to doing that? Listen, well, you know, now that you're asking me already, the next day I get such a headache, and sometimes I can't even stay up during the class. So get the pros and cons of the behavior. You know, you can include that as part of your part of the conversation. And so oftentimes, like when When you reflect back that, you can also say, it says, you know, I have some information about that. Do you mind if I share that with you? And those may be those aha moments and those times when change talk can start to come. And then you might want to use the scale and then with an action plan. And so you have more information here, very specifically how that can go. I don't really want to go over it because you will have this in your slides. It has the importance ruler. It has, you know, you use the communication strategies, for instance, like the ORs. All of that is going to make a difference in how you present a person-centered conversation with someone. I provided you with a template of a potential outline of how a conversation can go. And so this is just for you to kind of refer to as you get familiar if you want to practice the brief intervention. And so there are these pieces, and this could be easily a pocket card. The idea is that when you get used to strategizing, having a conversation in an intentional manner, because you're going to address a risky substance using behavior without actually saying that, you know, you're going to engage them in a conversation, and you're going to acknowledge and recognize, you know, what their motivation for being there is, what their goals they want to meet, and how that comes out in conversation. You'd be able to kind of refer to this process, and maybe that'll help you. And so this can be an impromptu tool for you while you get to learn how this works. Any questions about this? Okay. So that's why I suggest that really that you should get a motivational interviewing type of training on your own. It will really, really, really be helpful. Okay. Are the dialogues always direct? No, the dialogues are not direct. They really shouldn't be direct. The dialogues are very free flowing. It's just intentional on your part and how you use the communication skills. There is a change that possibly you're hoping to incite motivation around, but if the individual is not heading in that direction, no matter how you use your communication skills strategically, and they don't see any reason to, they don't see the association or the importance of how the level of consumption has anything to do with their health, then you can always make an appointment and come back and visit them and have them have another interaction. So brief interventions are two. Sometimes we can have a 15-minute conversation and in the moment, and it can be very effective. And sometimes we might need is okay, so, you know, do you mind if we meet up again? You know, let's make an appointment for like a week from now, if you're okay with that, and let's just just check in and see where you're at, because I know you came in for these services and I want to see how those services are going. Is that okay? Great. So at that time, an extended brief intervention would be when you meet with them again and then bring it up. And so not everybody in one shot, like it really depends on how comfortable we are and how efficient we are in doing it and how confident we are in facilitating a brief intervention. But once we start to do it a few times, it's like, I think it's so much more natural to what you already do. It's just that you do it with intention. So many times you would have one conversation, you hear some kind of change or some kind of idea, some plan, some motivation to do things a little differently. And so that can be so helpful. And so it should never be direct, it should never be a direct process, although it is directive because it's typically around a change. You might see the change, they might not, or the way you might want to bring up a point is to ask them how this, the screening score, could they tell you about, a day in their life, how they, how that works in their life. So if you don't mind, could you tell me, like, when you do drink, what do you drink? And if you're using a comfortable tone of voice, if you're using non-judgmental approaches, you're more likely to start engaging a conversation and learn a lot about the individual that they will be able to share with you. And there's so much more to this. Come to my 12 hours. So right now I'm going to go to the module 6, referral to treatment. Now you see there, it says further assessment. For many years, we've always had this component as further assessment, as referral to treatment. If I say it that way, and let me say it like this. So if I follow through on that component as being referral to treatment, I'm saying something very specific. That's a close-ended question, yes or no? So what do you think I'm saying? It says, I would like to give you a referral to treatment, to substance use treatment. What am I saying to the person?
Problem.
I would like to get you additional assistance.
So I'm telling them they have a problem. How can I tell somebody they have a problem when all I saw was this? All I did was screen. All we did was screen. Screening just identifies a potential issue to explore. That's it. It doesn't diagnose anything. Screening is not a diagnosis. And that's why I reiterate that time and time again. It doesn't matter what my experience is. It has nothing to do with it. That's not documented. You know, my gut instincts and my experience tells me that that person probably can benefit from treatment. That's not how we justify it. That's not how SBIRT works. There is a particular protocol. So that screening score, let's say it's the audit, it's up there maybe 13 or 14. And that's usually around the category that puts somebody at high risk of a potential alcohol use disorder, okay? So potential, it's everything, all the language should be consistent. So we don't say the referral to treatment can be so defined literally. So let's look at it a little different. So guess what happens? So you're having a conversation, and in that conversation, many of the challenges that have to do with substance use is coming out. They said, well, you know, I did see that you have a high risk for a high level of consumption. And as the conversation goes on, you can also say, so according to your score that we spoke about before, you know, if you like, I can always offer you a referral for further assessment. I cannot say a referral for treatment. A lot tends to come out in a conversation when they're comfortable with you. If they have a substance use disorder that has yet to be diagnosed, a lot does come out in the conversation. They're already trusting you. They're already comfortable. But I can't say that. Ethically, my responsibility is to say, well, if you like, I can, you know, according to the score, it does indicate that maybe that you could probably benefit from further assessment. I only do screening here. So would that be okay? Well, where would the further assessment take place? Typically, it would happen, you know, at a place where they provide substance use disorder treatments. That's a credentialed individual that does an actual assessment and a diagnosis. So what do you do? So what do they do over there? You know, are they gonna pull me in? They're gonna push me into treatment? I said, no, that's always a choice on you. I said, but I can tell you, I can explain to you a little bit about that. So the referral process itself, it's also about transparency, and it's also how you frame and how you present it. It's always the person's choice. So how you present it is going to be key. So let me bring this up. So that's why we put further assessment, because it has to be consistent with what we've been saying all along. We do a screening, we're not doing a diagnosis. That's not SBIRT. Where do we send somebody for further assessment? We're typically to a credentialed individual that usually works at a treatment facility. You know, I'm going to send you over to Javier Rivera. I know that he will be there certain days, and I can send you over to him. So also, since they're trusting in you and they're sharing information with you, and you're trying to and they're looking at the potential for the need for change, then also how you present a potential resource is also very important. So some of the things that happen here. So people who do get screened in primary care, you know, we talked about that 5% of folks who might have a high potential for substance use disorder or an alcohol use disorder. So in this component, in terms of referral to treatment, is for further assessment, or maybe they are asking at that point for specialty care. Well, we want to make sure that that score justifies that, and that we're able to provide it. We want to be transparent. So with the score indicates that you can probably benefit. And according to everything that you're saying, maybe you would like to have further assessment. You offer it that assessment. So what if they do want to ask about what treatment is? You know, so because so many people have different ideas of what treatment is. A lot of stuff that is heard and spoken about, but not a lot of it is necessarily accurate. And so there's opportunity for you to know something about treatment. This is typically, SBIRT is typically done on any non-substance use treatment facility. So if they're going there, if they have questions, you just have to be informed enough to respond to them. And so treatment typically has, you know, psychosocial services, medications for, usually for opioid and alcohol use disorders. And they have other wraparound services as well as some wellness activity. And sometimes even those referrals are part of their potential treatment plan can include going to self-help or peer support groups. And so treatment is considered provided within levels of care, often available in multiple treatment settings. Levels of care is determined by severity of illness. So one of the things that you can do is help prepare someone if they are going to a facility, and then a further assessment does provide, the opportunity to understand that they can benefit from treatment. You can say, well, there's different kinds of treatment. Do you have any questions about that? What do you know about treatment? So each inpatient treatment is reserved for those with most serious illness. Different levels of care include both outpatient and intensive outpatient. Inpatient is kind of referred to, I don't think they could be referred to as rehab anymore, but medications for opioid use disorder or alcohol use disorder. Medications are for both. We always think about opioid use disorder, but very severe levels of alcohol use disorders can also use medications. So there's also detoxification processes. The recovery support services, there are different types of recovery support services that make this the whole opportunity of going into the treatment environment very much more comfortable than what somebody's thinking might be. And so the peer services, peers housing supports, using recovery-oriented systems of care to be able to provide persons support around their unique needs, hugely important. There are also residential programs that are into stabilizing an individual, of course, rehabilitation, but reintegration back into the community. So there are different services, or different program opportunities that help an individual feel comfortable going back in. Sometimes when I think about reintegration, I think about folks who are criminal justice involved. And so those programs can help those individuals as well. What's the interesting thing about treatment is that relapse rates similar to other chronic illnesses. One of the things that the treatment field has evolved with, thank goodness, is that they understand that an individual can actually have a recurrence as easily as with any other medical issue. A lot of folks who do have a relapse or recurrence, something that used to elude the whole discipline in the addiction field was that because those neurological processes have been rewired and have been conditioned to doing things a certain way, that just because someone abruptly stops doing something right now doesn't mean that the mind has already kind of caught up to doing things differently. And so recurrence isn't the most natural thing in the world to happen. It happens with hypertension, it happens with asthma, even with somebody who gets a diagnosis of diabetes. Somebody gets a diagnosis of diabetes or has some gastric issues of some kind, and then they get given a diet that they have to follow. And how easy is it to suddenly change all the things you've ever eaten into including items and your new diet that you're not used to eating or even liking. So that's my pet peeve with that. I think that should be culturally appropriate instead of just giving a standardized, list of items that should be eaten and ones that shouldn't be eaten. But there's also this idea that change can happen just like that overnight. People are not light switches. It takes time to adjust. It takes motivation. It takes constant support, and so it's more likely than not, and more natural than not, that an individual can go back into the behavior that was risky or put them at risk in the first place. It happens with other health conditions as well. So the other thing about making a referral is that up to 50% of people with serious alcohol substance use problem will not show up on their first appointment if they're put on a waiting list. If they're put on a waiting list, a person can easily change their mind. It kind of depends. And so what we talk about a lot in SBIRT is how do you make these referrals successful? Well, a couple of things is you want to ensure that the language that speaks to the benefits of further assessment, that we don't diagnose, how you bring it up and how you frame it, is the person aware or range of options that might be offered to them if that assessment comes through with a diagnosis. So we talk a lot about a warm handoff in referral. Okay, so let me stop here. So how many agencies here do warm handoffs? Do you folks do that? Okay, good, excellent. So let me ask you, so what is a warm handoff? Anyone, and you can put it in the chat box if you like.
Hi, this is Ashley. With my old team, what we did was with a warm handoff, you make the referral is accepted. You go with them to, you meet with the client and the new team for the intake and kind of explain to them exactly what is going on. And you are there to kind of be the facilitator of the transfer.
Very good. Thank you, Ashley. At this point, if you're offering a referral and they're at a point where they are looking to accept it, they must have trusted you enough to have a lot of information sharing with you. They feel comfortable with you. So you want to be able to actually see, walk the person over if at all possible. There are many people, many organizations rather, that do have these protocols in place. And so if they're trusting you, they probably will trust you who you're gonna hand them off to. If you could walk them down the hallway, if you could walk them over across the street, that would be awesome. There are some places that can actually do that. Some other places might need a warm handoff done a little bit more indirectly, but if whenever you can and walk them yourself, they are still going on your best, your reflection of their wellness, of their best interest in heart. So they're trusting what you're saying. And so I think this is fantastic. Let's also think about, yes, it's directly provided to one to another. And so the thing is, so I want to ask you folks one more thing. What do you think? What are the essential components of an effective referral? Considering that a lot of people not necessarily don't like to go to, may not necessarily follow through, you want to create the opportunities to increase the likelihood that they will follow through. A warm handoff would be helpful. What other things are critical to making an effective referral? The client is willing to accept the referral. Yes, we start there. Joanne?
Client or the individual actually understands what the referral process looks like. They're also, the expectations are set, much like at a doctor's office. When you go for a referral, you might have a 10:30 appointment, but you might not be seen exactly at 10:30. What I think it's helpful to walk the client or individual that you're sending to the referral through what that process could look like for them. Also, if you have a name of the person they're going to see, to provide it to them. And also make sure that the referral agency has everything that they need prior to meeting the client. I'd also explain again or reiterate again what confidentiality is, so that they know that the information is staying with whatever they share, stays with that agency unless they give permission.
Okay. All right, let's talk about it. And thank you so much, Joanne, and everyone else. So let's talk about, what is required by the agency. What is it that you have to know that has to be submitted or provided or be available so that person can go get an assessment somewhere? What is it? What do we refer to that as? Can they just show up one day or maybe one of your care coordinators or peer advocates are, gonna take them and they just show up? Is that it? Okay, who's made a referral in the last 2 weeks? Okay, what was it that you had to consider when you made that referral, Roberto? What came to mind for you? What did you do?
Well, yes, there's some different places that require different things.
Yes.
One place in particular just asks for the medical insurance and the client's phone number. And that's what we have to do. In other instances, and they contact the client directly and they do everything themselves. In other instances, it's more difficult. We need an M11Q, we need a biopsychosocial, we need psychiatric evaluation, and sometimes if the client don't have it, that's a barrier for the client to go immediately or soon to the referral.
Okay. All right, so thank you. It depends on what referral and the criteria. That's good. Thank you. That's just what I was looking for. And over here, I'm thinking as part of SBIRT, what we're doing is we're sending for further assessment. We're not necessarily having somebody that says, okay, we need to make sure your life is completely open. We want everything. We want the individual to be able to go to the place and have what they need. That increases the likelihood that the person will follow through on that appointment. Remember, we're going for further assessment. Now, so other things, let's think about this. Let's use the framework that I've been talking about. So what is the individual's culture? You know, is this place that's going to do the assessment, are they culturally informed? Also, what is the person's preferred language? It's not just speaking the same words in English. Comprehension is huge. It's a huge factor in terms of transparency and clarity of messaging. So language is important. Is this place that we are offering a referral to, does this place have the language skills appropriate for this particular individual? Sometimes you want to have more than one choice. So a list of different facilities that can do an assessment. Stigma is still a huge part of this, so let's consider. We might have some common collaborations or collaborative agreements with different community resources, but do we have some that may be in their immediate, that is easier to get to travel to? Do we have some outside that may not necessarily be in common places that person tends to engage in? You know, there's some communities where people's friends and families might be more likely to be present at. And so maybe somebody is willing to do an assessment at a place that is not necessarily where they're going to see people they know. Stigma is still a big part of this. Let's consider more than one option. So, and then, and Roberta just spoke to this, and so did Joanne. What's the referral criteria? Is there a particular medication, insurance card they need to have? Some places you didn't need medical insurance, you just needed to be what they call Medicaid eligible. Or also sometimes you need your ID, and some folks may not have their ID. Is that available? So you have to know specifically what that is. I always encourage that if they're trusting us and we can't necessarily walk with them, at least we can mention, listen, I know that Sylvia's going to see you, maybe Tracy will see you, or my friend Jorge may see you. So I know some folks that, you know, I'll see who's available. Let's work out a day and time that works for you to make it easy. And then we'll see which one of our colleagues will be present, and you can engage with them. Sometimes mentioning someone's name, you know, it doesn't have to be first name, it could be first and last name. So the idea is when you mention a name that a person that you know, that familiarity can also resonate with the individual. The warm handoff is important, and also do a follow-up. You know, keeping the door open, if someone put this in the chat, keeping the door open also speaks to being able to let somebody know, listen, you're, you know, love to like learn, you know, what, how the appointment went. Do you mind if we meet up again? And make that appointment then and follow, so they can follow up with you, or you check in on them, how they're doing. Or if they're doing another, they have another appointment with another service within your organization, and you know they're going to see, you're going to see them, they're going to be at the facility, maybe within a couple of weeks after the assessment appointment is done, then you go and say, do you mind, Dennis, I know you have to come see the nutrition program. Do you mind if we check in? And I'd love to see how you're doing, you know, how things are going and how it went for you. You know, so it makes it just a natural part of a conversation. But the successful rates of referrals really is contingent upon you knowing a lot of this. One of the things that we weren't always doing and we started to do was the language and culture piece, because it's so important. If a person does get assessed and they do end up being offered that they qualify for services, you don't want to set someone up for failure. You want to make sure that that facility is able to provide culturally appropriate services to that individual. We have such high diversity in our communities today, such high diversity, more than ever before, I believe. And so we want to set them up for success. And so someone can go get the further assessment and they can choose to go into a program or not. They can even think about it and come back and see us and we can continue the conversation. And so an extended brief intervention that can also fall under an extended brief intervention, and that is also billable. Very good. So the whole idea is not to rush the process, not to tell the person, to keep them engaged and asking permission and where do you see yourself? Well, the screening score indicates that you have a high risk of substance use disorder, but I couldn't tell you because I'm not assessing you. Would you like to go to a place and get further assessed? And those people and those folks tend to share a lot of the challenges associated with that level of consumption. And so referring to a program that is for or does not take the person's insurance, huge. If we don't know where we're sending them to, we shouldn't send them anywhere. We should just make an appointment for them to come back to see us. I remember when I was doing direct services, geez, I remember the Rolodex. That's bad, that's really going back. There used to be always several choices, but we didn't always know who was in business, who has open opportunities for intakes or for assessments on certain days. The familiarity with that is so important on our part. And so we don't want to kind of miss a step here because we lose the opportunity sometimes with our clients to be able to give them that continuation of care. And so we also don't want to dismiss the opportunity of what medication for opioid use disorder can be. So sometimes when what people call medication for assisted treatment, which has a real negative connotation, so a lot of folks associate that in a very different ways, not necessarily in effective ways. And so maybe you might need to explain that sometimes what we've seen, and this is what the research has come up with, what has identified is that sometimes providers themselves will not necessarily bring that up because they have their own bias against, say, methadone, buprenorphine type of programs. And so when we understand that it is also a health approach to being able to help someone engage in the habit of living life in little health and healthier ways, while the body is not forcing them to go back out and use, because this is essentially what those medications do. They stabilize them so they can get their own level of recovery. And so sometimes that's kind of biased on some of our partners. We don't offer that as a potential option. So we don't want to see the person as resistant. We don't want to see the person as self-sabotaging. We don't want to see the person as dishonest, manipulative, or not. That is nonsense. Really what we're seeing is a person who's trying to do the best they can with what they know at the moment. And so, and I can't be even more accurate than that. Someone whose brain, whose mind has conditioned to thinking and doing things a certain way, who may be at risk, or who may benefit from further assessment. Folks tend to do, like any other human being, people tend to do what they need to do for themselves according to how they see it. It's not necessarily the healthiest way. They may not have the capacity to do or see more than what they see, but that's why we need to look at folks as a way of helping to meet them where they're at, so we can incite that motivation, help them make connections, and hopefully help them see that there are opportunities they might want to consider, but that's up to them. We don't tell anybody we don't want to think like that. And so any comments, any questions about that? Let's see. A follow-up phone call is also necessary. I think that's great. Okay. How often do we do that? How often do we know? Are you all familiar that all your resources are culturally and linguistically appropriate for different people? Okay, I'm not gonna put anybody on the spot. So one of the things that we are encouraged to do is just to be mindful of, even in your staff meetings, that can be like a point, an agenda item to kind of just briefly discuss with staff. And I don't know. So these are, these places are still available. They're building capacity to be more culturally informed with the different communities. We have more diversity now. If it's indigenous people, then we want to understand which of the indigenous communities are in our that we want to refer to. If it's someone who's Guyanese who really is more comfortable with Punjabi, just the facility that we're sending them to do a further assessment, do they have the capacity? If someone only speaking Spanish, but they're not Medicaid, they don't have Medicaid, doesn't mean that they're undocumented, but they just don't, they have certain challenges in terms of how they engage, to have a place where they can go to. So really thinking through this process instead of just automatically, well, I got these 3 places, I can send them to one of these. Because if we send them to some place that doesn't work for them and we don't check on them, we might never see them again, but they may not get the supports that they can benefit from. So that's really important to understand. So the last piece of this SBIRT process. And so I'm just going to cap on the highlights. I'm not going to delve into it too much, but I'm going to, there's some things that need to be understood. And so in terms of the business of SBIRT, so one of the things, and particularly when I work with like hospitals, research is a huge motivation for hospitals to incorporate a program in their infrastructure, in their setting. And so when you can see the cost effectiveness, when you can see, you can prove and make the case that this process is effective and it's worth incorporating, that's helpful. So you can look at different studies that have been done on the efficacy of SBIRT. In particular, here in this link right now has 5 cost-effective studies for SBIRT. But if you know you're working, if you're working with a hospital and you want a hospital-based or healthcare-specific environment, then you want to give them those kind of studies. And the hospitals that I work with, I tend to give them those kind of studies that are for the medical community that shows the efficacy. If it's viable, if it's helpful for the patient, if it's billable, if it can be done feasibly without disrupting operations. Those are all important components for integration of a new program. And so SBIRT happens to be one that can meet all those. So reimbursement of services, New Jersey Department of Health Human Services have developed an SBIRT services reimbursement system through Medicaid. So has New York. And it's really about understanding the qualifications of the type of the individuals facilitating SBIRT. It's also about what type of facility it is and what area are they in. And even though there's autonomy between how Medicaid services work for different, reimbursed for different services, they tend to have just certain common aspects that they require the organization to engage in. So for specifics on reimbursement, it's important to work directly with the billing department. Not just Medicare or Medicaid, but commercial insurers also can also reimburse for services. And so you have some live links there that even though when you get this as a PDF, the live links will take you to these places. So providers who are eligible to bill for office-based SBIRT services. These are the folks that on their own, they can bill. They don't need a whole team. So physicians, all they need to do is a 4-hour training such as this one. So performed by another, so these are services to maybe performed by another provider type under the supervision of the physician. So also nurse practitioners, midwives, and psychologists in order to facilitate and do a screening or even an informal screening with a validated approach, validated instrument instead of the self-report, and then actually do the intervention and referral. All they need, this level of competency, these folks, all they require to do is a 4-hour training, which is why this training, which is why I scheduled this training. Those who are eligible to perform and bill under a licensed provider, where the licensed provider, like the folks on this slide, where they could do the oversight and sign off. So the folks that also need to do a 4-hour SBIRT under these licensed providers that would sign off as a physician assistant, registered nurses, And these are the licensed practical nurses, master social work, clinical social work, the licensed mental health counselors, the family therapist. And so these folks only require a 4-hour SBIRT training. Let me just say this, and I should have put this on the slide, and I will include that in the set that you're going to get. For those folks who are not licensed, for health educators and other non-health licensed individuals and professionals, what you would be required to do a 12-hour training, and that's a 12-hour training. I get requests. I get that requested like all the time, almost every other month. I'm doing the 12-hour. The nice thing about the 12-hour, it's worth putting in the effort because we go into the skill sets. We go into really practicing about how to have that conversation. We go into like setting the atmosphere and building up that rapport and that safety issue. We go into all of that. We also go into this part. So licensed or unlicensed health educators or the providers are required to do the 12 hours. And they should be they would be supervised by the practitioners on this side so they can facilitate SBIRT and have those, the SBIRT services built. And so this is the Medicare reimbursement codes. And often when I tell organizations that I work with directly is I give them a copy of this, even the folks in HR and the billing department, just to ensure that they're familiar with, they're already familiar with the reimbursement processes, but they also have to be more familiar with the specifics around SBIRT. And so there's some guidelines available here. Commercial Medicare reimbursement codes here, and some additional information here. So one of the things is that this piece of the training always like identifies some of these approved screening tools. You would have to certainly make sure that you're working with your Medicaid and Medicare offices and make sure that the validated screening tools that you're using in your organizations are acceptable for billing for SBIRT. So here's something important that sometimes get lost a lot is how to document for SBIRT. You know, a lot can happen in the conversation with the individual, even within a 15-minute time frame. And yet when we provide documentation for billing, we only need certain things to consider. So how the information is on what type of service did you provide? Did you do a screening? Was it a brief intervention? Was it a referral for further assessment? Was it 2-component screening and brief intervention? You know, what happened at the brief intervention? So you want to know, okay, what's the instrument that was used? And what was the score? Another reason why you are required to score and interpret screening. Otherwise, what's the point of asking the questions? So whether screening was positive or negative, because we have to see a flow of the activity and the justification for them. And so where goals was a brief intervention facilitated, whether goals were developed or not, is there a follow-up appointment that was scheduled? Was there a referral made to an SUD provider, which means they're getting for further assessment? So, and of course, something all of us know, we could probably know this in our sleep, is that we know we have to have a start and end time of that session that we document, because they're going to bill you almost a certain amount of time. And so all those and all that information needs to be in your documentation. You don't need a whole lot of other information. You don't need 3 screens. You don't need 3 scores. You know, it has to be clear and concise. So one of the things that healthcare communities do have the opportunity from, and some agencies do too, is how to store SBIRT information in an electronic health record. And so that makes it easy for anyone to pick up on a particular individual's, you know, process where, okay, they have done, they have responded to a substance use screening, and someone else can see where the score and interpretation is, can pick up from there and facilitate a brief intervention. And so SBIRT data in the HR is retrieved easily for billing purposes, but also sometimes research will tap into your systems or want to tap into your systems with your permission and, you know, and gather information for their studies. And so implementation resources. This is really simple. Implementation resources. There's several different options here. If you wanted to integrate SBIRT into say one of your programs or into your setting, these are resources that you can use. I highly encourage that you use an SBIRT expert. I will volunteer to be that person. You know, that's just the person who's going to help you understand how your current environment can integrate SBIRT within your facility. It makes it's a way of doing it without obstructing operations, seeing the feasibility of it, and helping you understand, you know, the different points and how it can translate in your setting and make it happen. And so also, I will say that New York State Oasis is there as well. We probably didn't need all the time that I thought we needed. Any comments, any questions? What is not understood? Because I went through this so quickly. This is very different than a 12-hour presentation. Okay, so let me ask you a question. Well, let's do an informal quiz. What is the goal of SBIRT, which is screening, brief intervention, referral, treatment? 3 components as a model, SBIRT. What is the goal? What is the primary goal of SBIRT? What do you remember?
Is to identify and intervene effectively.
Very good. Thank you, Faith. Yes, Peter, it's to gather information. It is. Remember, we're gathering information when we're doing the screening. We're doing that. We are gathering information. Brief intervention is a dialogue based on the screening score, if it's justified, right? We need that justification. And potential referral. Not everybody's going to get a referral for further assessment. I'm talking about to folks who are not doing treatment. And so if there's a risky level of consumption of substances, you may be able to have a dialogue with someone that in 15 minutes, they might consider doing things a little different and you can check in with them again. So really what the primary goal is to identify and intervene with folks who are in moderate high risk of substance use, of psychosocial problems and other related issues related to that correlates with their level of consumption. The primary goal is to help identify the at-risk folks and their behavior. Not substance use disorder. You have a whole bunch of different approaches that work for that, but that is not the primary goal. We want to work with also with the folks who do not meet the criteria of substance use disorder, but we can also help. If they happen to have a high screening score, we can certainly, you know, start to help address the issues of potential substance use disorder by providing a referral. That is also justified by the screening score. Okay, what else can you take and tell me about SBIRT? Does SBIRT work with some people? Who does it work with? Or who does it work with best? And that is a trick question. So it's for anyone and everyone. But what are the settings what is the one setting it doesn't get used at?
When somebody's already diagnosed.
There you go. So that means the substance use treatment setting is not the place where SBIRT is used because you already have some evidence-based protocols that you use already in there. SBIRT is not for that. SBIRT is for those folks who are at risk. But the folks who might need an assessment from those facilities, that we can help segue that too. But we want to be able to help these 4 to 6 people per person who has a substance use disorder. So imagine all that work that you're already doing with folks who do have that disorder. There's a lot of people out there can benefit from your approaches. So the component screening, brief intervention, referral to treatment, which is for further assessment. Those are the 3 actual components of the model. Any combination of that, not including all 3, is not SBIRT. If you don't facilitate the process the way it's designed, you have an opportunity to compromise the outcomes. Then you no longer have fidelity. Then it's not the SBIRT model that doesn't work. It will probably be us. If you're going to build, you're going to have to justify those processes. It's easy because you already have the skills. It's just a matter of doing it intentionally. Any comments, questions, anything that kind of comes up, anything that was confusing? Julian.
Yeah, so I am a health coach and a health educator. So where I'm seeing this being useful potentially is in one-on-one health coaching sessions. And I'm just curious if there's a way to use this in bill if we don't have a physician or another higher level person above us. We have other employees where I work that contract with hospitals, and so I could see that working for them, but for me, I'm not under like a social worker or a physician or anything like that.
So you would not be able to bill for the services. You'd be able to help folks, but just not bill for the services. A lot of people in a lot of agencies are using SBIRT without billing. We mentioned the billing because in the 4 hour training, that component is required, so folks can get familiar with what, how that process can work. But a lot of people are using SBIRT without having to bill because it's just done in a brief, as a brief intervention approach. It's like so effective, So you wouldn't be able to bill, but it doesn't mean that you can't use some of those components. Heck, let me just tell you how applicable it is, since you just triggered something I remember now. So there was an organization that required our support, our technical assistance and implementation support. And I worked with a lot of folks, certain folks within that organization and different programs that they had to, so they can have the competency to do SBIRT. What was interesting is I found out that 2 of them were addiction counselors. So they weren't going to use it for substance use. But they've turned around and took this and used it to help smoking cessation support with their clients. So that was like a really nice perk. It is applicable for so many other risky behaviors. I am currently engaged with Mount Sinai in a pilot study, and we are using it with community healthcare workers, using this approach to help increase awareness and engage the Black and African American community in terms of depression and anxiety, and helping them link to healthcare screening. So that's been helped there. Also using it in a different one with Columbia for colorectal cancer, and helping to link folks to those health screenings there. One was mental health, and the other one is health screening. And so this is applicable in so many different ways. It's about risky behavior, how we make the association without using an intrusive direct approach. It's just a matter of helping folks understand, this is about your health, it's about your wellness. This may be impacting, let's talk about it. Okay. All right, so that's wonderful. So I really appreciate everybody's time and your attention here. Thank you so much. Maybe one day you could come to one of 12 hours, because then we really have fun, because we unpack this to the T's.